Welcome here in Parma. My name is Tino Gesualdo, and I am the project coordinator of N-PATH. We will start this morning welcoming Dr. Giannini from the European Community Office. I think that she's already online. Hi, Dr. Giannini. Nice to see you again, and thank you very much for sharing with us this multiplier event here in Parma. So I know that you have a very busy schedule today, so we are starting on time. So please, it's your turn. Thank you once again.
Let me introduce myself. I'm Lucia Giannini, and I'm working in Brussels at the European Education and Culture Executive Agency, which is an agency managing programs on behalf of the European Commission. So we are part of the European Commission, of the big European family, and we are in charge of managing a relevant, let's say, part of the famous Erasmus Plus program. More specifically, I belong to the Knowledge Alliances team. So part of my time is dedicated to selecting and monitoring the work of the Knowledge Alliances projects. And N-PATH is one of these Knowledge Alliances projects, and I have the pleasure to be the contact person, so to follow also the work of N-PATH. For those of you who might not be familiar with Knowledge Alliances, because I know that today it's not only the consortium, but also external people, I just want to give the very basic information about Knowledge Alliances. This is an initiative that started in 2014. This is when the first Knowledge Alliances projects were financed. At the time, only the 10 pioneers who started the action. The European Commission saw from the very beginning that there was an interest in this action, and throughout the years, the budget that was assigned to the Knowledge Alliances from the European Commission increased, and this allowed the agency to select every year more projects from 10 in 2014 and 15 to 20, 2016 and 17. And from 2018 onwards, we have been selecting around 32 projects every year. However, what I want to underline is that every selection in Knowledge Alliances is extremely competitive. The quality of the proposals is very high, and therefore, I want to congratulate the N-PATH consortium for having presented to the European Commission a very strong proposal that was considered really very good candidate for funding. These Knowledge Alliances projects have the peculiarity of having always a collaboration between the university world and the world of business and the enterprises, and the European Commission is very keen on increasing this collaboration and financing this type of projects. And to conclude, I must say that I know that you've already worked a lot in the N-PATH projects. I receive often updates from you, and I'm extremely pleased, and I hope that this very good collaboration with the agency in Brussels will continue, because we in Brussels, we are interested in really seeing what the Knowledge Alliances projects produce, and we want the Knowledge Alliances family really to grow and to be stronger. And I believe events like the one of today are extremely important to have a multiplying effect outside the project consortium. As a last note, This pandemic period has created additional difficulties to all the projects, and in Brussels we must say that we are very pleased by the fact that your project and the other ones, you have really tried to not to lose time and to work online and to find ways to continue working, even if physical meetings for a lot of time were impossible to be held. But today it's an hybrid meeting, so it's already a step forward, and I really hope that in the near future your project will be able to organize real events, meeting, because meeting the project consortium is also a very important part of your work. So thank you for having coped with also with the pandemic very well, and I wish you a very good continuation of this journey in the N-PATH project. Thank you very much, and have a fruitful meeting.
Thank you, Dr. Giannini. Thank you very much for your kind words regarding N-PATH. And we are here in Parma. Today we will have more than 70 participants for all over Europe. So we are pleased for this, and I should, thank all, the organizer. They did a very outstanding job, because we are here in an hybrid format, and we have a beautiful room with the state-of-the-art technologies that enable us to have a meeting that, being a hybrid, looks like that we are in presence. So technology is improving, and Knowledge of Alliance is looking forward for it. So thank you once again being with us this morning, and we wish you a very nice day, good work, and we hope that we will have you again join us in the next meeting. Probably that will be nice to see you in presence. That will be very, very well appreciated. Thank you very much, Dr. Giannini.
Have a good meeting. Thank you. Bye.
Well, good morning. We are on time. We are using a Swiss time, I think. And thank you very much for participation. Thank you for all of you that came, in presence. But I would like also to thank the participants that are online. I saw on the screen that there are more than 40 people right now, 40 persons. I think that we are 45. I don't know the backstage if is 45 are the presence. We have also today, we meet for the first time our resident, because we are starting the program. But I would like to introduce myself. My name is Tino Gesualdo, and I am a full professor of nephrology, working at the University of Bari, Italy, and I am the project coordinator of N-PATH. If I can have my first presentation, N-PATH stands for Nephrology Partnership for Advancing Technology in Healthcare. You can see this is our website, www.npath.eu, that please, try to surf it, because there are, many information for you. And today we have our multiplier event. The multiplier event is a meeting that would like to share our knowledge with the other one. Also with colleagues that are not involved in N-PATH, because Dr. Giannini reported that the mission of the European Community is to share knowledge and to create networking, and especially networking between higher education institutions, universities, and small and medium enterprises, so business industries and all, the stakeholders that are involved in this field. So why we build up this consortium? Well, these are our numbers in nephrology. 850 million people worldwide have kidney disease, more women than men, 12% versus 10.4. And if you see our number and we compare to other disease, diabetes mellitus counts 422 million, so we are double. And cancer 42, HIV 37 million. These data were presented by Dr. Okusa in the ASN, but were reported by Dr. Jagger, that is Katie Jagger, that is our colleague that is running the registry, the ERA registry in Europe. So chronic kidney disease, as you know, is becoming a social problem that involves not only nephrologists, but also GP, general practitioners, as well as other specialists. We know that this is a progressive disease that is often linked to risk factor as hypertension and diabetes, which in the last stage requires dialysis or transplantation. And we know very well that an early diagnosis can allow an adequate management of the disease in order to slow down its evolution toward the more advanced stages. Now the question is, the numbers are high, 850 million affected by CKD. But why we are getting a new syndrome? We are getting a new nephrologic syndrome that is called acute fellowship insufficiency. So we were asking us why we are getting this problem, since there are so many persons in the world that are waiting for our support. And if we see the residency program, these are a residency program in the States. As you can see, there are more than 51% of program, and 68 out of 134, and at 32% of position, 120 out of 374 that are going unfilled. So we are not attractive. Nephrology is not sexy. Why? So we should ask to us. I was, in charge of a residency program in my university, and I was asking to myself, why our residents do not like nephrology? So we should actually review this point. Now, the situation is not the same in all countries. There are countries where, for example, Spain, Greece, Italy, where there are a good number of nephrologists per million of inhabitants, per million population, running between 40 and 50 per million population. But there are other countries, such as UK, that there are only 8 per million population, almost nothing. Maybe different health system, organization. By the way, as you know, Dr. Sharif reported in Clinical Kidney Journal, global expert group predicts reduction in the nephrology workforce over the next decades with potentially serious implications. Multiple factors are responsible for this, although the reason may vary in different countries. Now, let's try to review the most important reasons that are giving shortage to nephrology. First, lack of exposure, probably. So we will discuss this together. lack of exposure to nephrology among students and residents. Maybe we needed to work in the medical school, trying to let understand our medical students how it's important nephrology, since we have 850 millions of persons that are affected by renal diseases. Second, decline interest in nephrology among trainees. So we did it, for example, in Italy, a survey, and we realized they asking us more practical courses, more practical events. And inadequate training, are we missing mentors? You know, the residents like to have the good mentor, the mentor that is challenging the residents, the mentor that is pushing on him. And maybe, and we should think about this point, maybe erosion of nephrology practice scope by other specialists. Let's think to the ICU. Let's think to the cardiology. Now cardiology, they are pushing a lot in the endovascular approach. And the cardiosurgeon, they don't like it too much. So it's time that we wake up, I think, and let, become nephrology more sexy. So what can are the strategies for recruiting excellent fellow in nephrology? I think that all of us must ensure that those who complete training are highly skilled with expertise that distinguish nephrologists from other specialties and prepare to translate new knowledge into improved outcomes for patients with kidney disease. We needed also to train mentors. Excellent teaching and mentoring are the most important factors for the satisfaction of fellows. The fellows are looking for mentors. They needed to be trained by the right mentor. And maybe we need to establish collaborative network. Is what we are doing today. We are doing networking among Europe. We needed to develop together a core curriculum, the same that should be applied all over in Europe. And in this, we have on board of this consortium two European society, the ERA, and I welcome Dr. Fontana, and I thank, Dr. Fontana and her staff for all she is doing for us. And she was organizing this beautiful event here in Parma. So we have the ERA, the European Renal Association, and we have the VAS, the European Vascular Access Society, that can spread this knowledge. It can help us in building up a core curriculum that we can share with our university. The consortium has inside 8 universities, 2 small and medium enterprises, and 2 European societies. Very nice group. Working together, making networking, trying to revitalize the joy in the practice of nephrology and convince trainees how exciting a career in nephrology can be. So I welcome the 40 residents that are today, with us, because they connected. How many participants do we have now? The backstage, can you give me a number? In this way we can say hello to everybody, because this is an hybrid format. It's not easy, to communicate, but it's also informal. We are here to make a networking. This is the main goal, trying to get the right networking that should revitalize the joy in the practice of nephrology. So how many participants do we have it? Here we are almost 20, 15. We are 15 in presence, 45 and 45. So we are 60. Very good number. Very good number. This is for us is a success. And we have also, you know, the residents that have been selected, and we will see. Huge success. 23 countries. So that is very, you know, is a very, very nice results for us. Very good. So what the core curriculum should have in? What the residents is asking to us. By the way, since we have residents together with us in this hybrid format, we should discuss also with them. They can ask because we can improve, you know, our N-PATH program, because if they can send us suggestions, and we will try to accomplish what they are asking to us. Should be, you know, a very dynamic course. So the core curriculum in nephrology should have in pathophysiology of renal disease, AKI and CKD, should have, you know, knowledge regarding renal replacement therapy and end-of-life care, a sound knowledge of measure randomized control trials and international national guidelines in the field of nephrology, dialysis, and transplantation, clinical pathological correlation, case studies. They like it a lot. You know, I saw my resident, they want to discuss the case, what they should do first, what I should do in this patient. I would like to know how to treat him. And what we are doing with this course, procedural skills, ultrasound, renal biopsy, insertion of central catheter, PD insertion, are all procedures that the fellow, the residents wants to learn. And I would like to know from them also if they, why they have participate in our program. That should be nice that, you know, somebody of you will, you know, write us on the chat. Or maybe I don't know if they can be connected by voice. I don't know if the platform able them also to get in with voice. We will say, you know, later. And we needed also to build up in Europe new research facilities and educational facility where to train these people. Because not a lot of us have the possibility to have the right environment where to build up, you know, expertise. So it's time that we train the next generation. And we needed to let them become and to enjoy what they are doing. Well, not saying, you know, a nephrologist as a superheroes. You know, the nephrologists that save, you know, lives. So this is our mission. And, you know, I choose nephrology because I had this, I was pushing myself, you know, on this. I was saying, I want to be a nephrologist. Why? Because there is so much to do it. Let's do it. So, and this new generation should be trained also on what is on the stage now. Artificial intelligence, augmented and immersive reality, simulation, and navigation. So once again, please go on our website. You will find all the information when, you know, the program starts, what kind of path is inside, because we have now the first European advanced training course in diagnostic and interventional nephrology. Will last 2 years. What are the main goals of N-PATH is refreshing the clinical scope of nephrology and promoting the nephrology careers at the European level. It would like to develop a multidisciplinary educational path with patient-centered approach, focusing on interventional nephrology, and will foster the knowledge transfer between academia, universities, and business sectors, small and medium enterprises, in order to tackle the risk management in health care. Think about it, risk management. Why using phantoms? Why using a procedure, interventional procedure on phantom? To reduce risk management. They want to go first on phantoms and after in the real life. This can train the fellow better than what we do. This is our consortium. As I was saying, 8 universities, University of Bari, Amsterdam, Prague, Maastricht, Patras, Barcelona, Parc Taulí, University of Milan, Ljubljana, the ERA, the European Renal Association, the Vascular Access Society, Eureka, that is our small and medium enterprise, our partner, that is developing a very dynamic and updated e-learning platform that all the residents will use in the next 2 years, as well as EMAC, that is a small and medium enterprise that will they will introduce themselves later, that is supporting us with all the technology that we needed to train the fellow that are getting inside of our program. These are the curricula, 4 curricula. The first curricula is REMAP, is called REMAP, is a renal expert in renal molecular pathology. The second curriculum is renal expert in vascular access. The third curriculum is renal expert in medical ultrasound. And the fourth curriculum is renal expert in peritoneal dialysis. And you see what, you will learn, what, the fellow will learn regarding each path. What is the methodology that we are using? Is a blended technology, is a blended learning approach where there will be face-to-face learning, meeting in several sites, as well as online learning using an e-learning platform. Moreover, we will use modern facilities, experienced tutors, cutting-edge simulators, and augmented reality tools, as well as e-learning platform regarding the online learning, e-learning platform, unpublished learning materials, expert live discussions, and customized mobile app. What we will release at the end of the program? Of course, an e-learning platform that, since we have been granted by the European Community, will be open access, so will be available for all. During these 2 years, only for the fellow that get it inside of the program. And this fellow will get also some academic certificate with 29 credits, university credits. The N-PATH goal is to make nephrology career more appealing, more sexy, by creating a community able to engage thousands of nephrologists worldwide. What we have done already? Well, the first kickoff meeting, we held the first kickoff meeting in December 2020. The 16th of December, we started. And actually, we launched the application call for the students, well, actually for the residents, I should say, that are also students, but our residents, our trainees, was launched in May, and between July and August, we selected the 40 trainees, the 40 residents that got inside of the program. And with this, I thank you for your attention. And what we will do now, we will present our partner, that will report to you what is their expertise and what the residents will do when they will visit their units. And once again, thank you very much, Professor Ibeas, that is here with me, and Professor Gallieni. Both of them are partner of the consortium, but all the other one are connected online, and they will report their greetings to you. So I think that the first one that will speak is Nice from the Academic Hospital Maastricht. Are you online, Professor Nice? Hello.
Hello. Good morning, everybody.
See you again. It's your turn.
Well, good morning, everybody. My name is Maarten Snoeis. I'm one of the vascular surgeons in Maastricht. And we have a busy dialysis access center in Maastricht. And we would like to be welcoming all the participants of the N-PATH curriculum for the REVAC and the Re-PAD courses. And here you can see a beautiful picture of the old center of Maastricht that you can be enjoying while taking these courses. Our dialysis access center is rather specialized. We have a center of excellence in vascular access surgery. And that means that we see a lot of referred cases from the entire country of the Netherlands. We have about 70 centers referring to our clinic, which is about 3/4 of the Netherlands, who refer their complex vascular access cases to our clinic. So we're used to seeing a lot of complications and difficult access cases, and I think that the participants of the N-PATH curriculum can benefit from that. We do a lot of duplex ultrasound examinations, about 800 per year. Obviously, we take care of our own dialysis unit, which has about 100 hemodialysis patients, which accumulates in about 60 vascular access surgeries a year. As you can see, the cases for referred patients are actually much larger than the number of local cases. So in our clinic, we do a lot of unusual and more extensive vascular access surgeries than I think people would normally see in their own clinics, because we get a lot of referrals from the country. We do about 175 endovascular interventions, and next to all these vascular access cases, we also have a peritoneal dialysis program where we do about 30 open surgical intervention, and actually laparoscopic surgical interventions a year for these patients. Our patients are satisfied with us. We get about 9 out of 10 satisfaction scores. So that always is for me an indication that we're doing a good job at our center. So here's just to give you an impression of some of the things that we're doing in Maastricht. At the left upper part, you can see endovascular treatment of a thoracic central vein obstruction for severe arm swelling. At the right upper panel, you can see an open surgery for a megafistula with huge aneurysms that we completely corrected and did a revision with distal inflow, quite complex, long surgeries. At the right lower panel, you can see that we started our endovascular fistula creation program using the ellipsis technique. So next to all kinds of complications that we try to solve for the country, we also want to be at the forefront of new innovations in the field. So the participants of the N-PATH curriculum will certainly be able to cover also the endovascular creation of fistulas in our clinic. And at the left lower part, you can see the laparoscopic PD catheter placement, which we also do in an advanced way with fixation of the catheter and omentopexy. So also these advanced laparoscopic surgical skills, we can expose our participants to these things while they are at our center. With regards to education, I think we have a long track record in Maastricht by organizing the yearly European Vascular Course, which has a specific section devoted to vascular access. You can see here in the times that we used to, that we did on-site training, a surgical masterclass with a cadaver course, with experts in the field, educating young trainees in dissection of the vessels in the arm and creating anastomosis and fistulas and grafts in these arms. And at the right panel, you can see our central venous catheter insertion workshop, where we teach ultrasound cannulation, tunneling of catheters using models. Last year, due to the corona pandemic, we completely changed our schedule into an online training environment. So we have a lot of experience. We've gained a lot of experience with that as well. We did interactive video workshops with more than 100 participants. We even did online hands-on workshops where people were sent materials at their own house to be able to practice some basic surgical and endovascular skills like vascular anastomosis creation and catheter insertion. Part of this access course has been also a peritoneal dialysis course where we can use laparoscopy simulators, and we also had a live animal training at our animal facility where we did laparoscopic peritoneal catheter placement in a pig model. So all these facilities are at your disposal in Maastricht. Next to the educational things, we also are very active in clinical research. We have a number of multi-center randomized controlled trials currently ongoing in the Netherlands, investigating the best vascular access for older hemodialysis patients to make sure that with surveillance of the vascular access, we are doing a good job for our patients. And we are currently also in peritoneal dialysis access, doing a randomized trial on standard versus advanced laparoscopic catheter placement. So I think with all these activities going on in Maastricht, both on the clinical expertise, the educational part, and the research part, we are very happy to welcome all the nephrology residents who have entered the N-PATH program for the REVAC and the REPAT course in vascular access and peritoneal dialysis in Maastricht in the Netherlands. Thank you for your attention.
Thank you very much, Professor Noyes, and very clear presentation, very nice facilities, good training in Maastricht. And now is the turn of Professor Florquin that is not yet online, so we will, switch. Professor Goumenos from Greece, from the University of Patras, is connected. I saw him this morning. He was maybe the first one that connected. So, Professor Goumenos, are you ready to go with your presentation? We can see very well now the slides, so please go ahead.
First of all, I would like to thank you personally and to thank everybody of the consortium for this excellent initiative and for our participation in this program. I will show you a few slides showing, first of all, where Patras is. Patras is the third city in population in Greece. It is located in Peloponnese. About 300,000 inhabitants are in Patras and around area. Patras is an entrance of Greece from the west. And as you very well know, there is a close connection to Italy with Bari, Ancona, Venice, and other cities by big ships crossing the Adriatic Sea. Many nice places around Patras, but the most famous and most important is ancient Olympia. Ancient Olympia is located about 1 hour 15 minutes from Patras. You can see in the left side the entrance of the old stadium, ancient stadium, where the first Olympic Games started in 776 before Christ. And the whole area is excellent, and the people who are going to visit us will have the opportunity to go to this place and see this excellent place and the museum there. But of course they have to do some job during their residence here. This is the University Hospital of Patras, the main entrance. This is one of the biggest hospitals in the country, about 800 beds, 800 to 900 beds. This is another part of the building, of the main building, of the main hospital. It is very close to the medical school and very close also to a big building, which is the main place where the research activities of the medical school take place. Now, apart from myself, Evangelos Papakristou, who is Associate Professor in Nephrology, and Marios Papasoteriou, who is Assistant Professor in Nephrology, are going to be involved in the education of the trainees during their residence in our place, and also during the with the web lectures. There are also 1 consultant and 4 registrars in our department. We have 6 trainees in nephrology and 3 trainees in internal medicine who are doing the rotation in nephrology. And the foundation year of our department is in 1989. We have a ward of 22 beds in total, 16 beds for clinical nephrology and 6 beds for the Department of Renal Transplantation, who is incorporated to our department. The population area covered is about 1 million inhabitants of the West Greece. And we have about 80 to 90 patients on chronic hemodialysis, nearly 14,000 sessions annually with the patients on acute intensive care unit, and also we're doing about 150 plasma exchange sessions annually in our department. We have about 40 patients on CAPD or APD program. We are putting about 10 to 12 catheters every 6 months to a year. We follow up more than 1,500 patients in our regular follow-up, and we are performing about 60 to 70 renal biopsies every year in our department. We are in very close contact with the Department of Radiology, and especially with the Department of Intensive Radiology, where responsible is Professor Karnabatidis, and also Konstantinos Katsanos, the Associate Professor, and Panos Kitrou, Assistant Professor in Radiology, are the people who are involved in all this work in clinical field and also in educational program that will be in progress here via N-PATH. They are doing many procedures, wide spectrum of image-guided diagnostic and therapeutic procedures, employing modern X-ray imaging systems and state-of-the-art techniques for patients on hemodialysis. For example, insertion of tunnel dialysis catheters, more than 400 per year, endovascular interventions, thrombolysis, thrombectomy, endovascular AV fistula, stent placements, and also native arteriovenous fistulas and PTF grafts, more than 350 per year. Flow restoration in thrombosed central veins, subclavian and internal jugular, with thrombolysis, thrombectomy, and stent placement, more than 30 per year. They are pioneers in endovascular surgery and endovascular and interventional radiology, and they are very much experienced in the ultrasound guidance for all these procedures and also for education. That's why we are also involved in REMUS part of N-PATH. So our participation in N-PATH will be in a REVAC with web lectures on vascular access complications and endovascular AVF by both of these consultants, radiologists, professors in radiology. I think they can also show in real practice in the trainees who are going to visit us also endovascular AVF and vascular access complications apart from their teaching in web lectures, if it is allowed from the program. I think they can do it in a real clinical practice for the people who are going to be in Patras. Also, we are involved in REPED with both web lectures on anatomy and physiology of peritoneal membrane and post-operative complications of catheter replacements, and also on PD case recorded in the operating room. And we are take part in REPED hands-on training and also in REMUS hands-on training. And I think that we can give a full picture of many problems in endovascular surgery and also in ultrasound with searching with ultrasound machine to various vessels and also in general nephrology to our patients. Apart from this clinical work, as I said, we are developing our research program in this big building, which is very close to the medical school and the university. We have our lab there and our biorepository in patients of different types of chronic kidney disease. We have samples of tissue biopsy, renal biopsy tissues, and also blood and urine, and we are involved in big projects on progression of kidney damage. And this is our main interest in research in nephrology. And with this, I would like to close my presentation, showing you a nice picture from our place. This is a big bridge connecting Patras Rion with the opposite side. It was inaugurated in 2004 with the Olympic Games in Greece. I can invite all the people coming here. They will have a great time, and also they will have a good education in our department. Thank you for including us, and thank you for your attention. Thank you.
Thank you very much, Professor Goumenos, for this presentation of Patras and the expertise that the residents will develop, will master in Patras. So now we move from Patras back to Amsterdam, where there is Professor Joris Relofs that will present the facilities in Amsterdam. Joris, are you connected? Oh, yeah, well, okay, Joris, welcome. Good morning.
Morning to all of you. Thank you very much.
Thank you to you that you are with us today. So it's your turn. Please tell us regarding Amsterdam. What are the expertise and what are the facilities there in Amsterdam? More a renal pathology, more telepathology approach. So my best regard also to Professor Volkerin and Sandrine.
It's a pleasure to join you, although not live in Parma, but to join you from Amsterdam. So what we will do in the setting of the N-PATH program is a hands-on training in diagnostic nephropathology, which I will tell you something about. So if you take a look at the website of the N-PATH program, you will find this motto: new paradigms of learning and knowledge sharing. And that's exactly what we intend to do with our part in this great consortium. And we are really looking forward to that. We will participate in the REMAP program, so that's the renal molecular pathologists. We specially designed a 3-day hands-on course in diagnostic nephropathology for nephrologists in training. So in principle, all the trainees will come for 3 days to Amsterdam to study nephropathology. And our goal that we have in mind is to share in-depth knowledge of nephropathology with all these nephrologists of the future. And we think that that is really vital for high quality nephrology care in Europe and all over the world, because when nephrologists and pathologists are able to speak the same language and are able to discuss histology patterns they see through the microscope or on the screen, this will eventually improve patient care. So we will do this from Amsterdam. The Amsterdam UMC is now the largest university hospital in the Netherlands. We are affiliated with 2 universities, so there's a very rich academic climate, I should say. And because of that, I think the Amsterdam UMC always ranks among the top 50 medical schools in the world in several of these famous lists you always see. How about the Department of Pathology, where we will host the students? We are a large department with 300 persons working here, and among the 30 pathologists there are 3 dedicated nephropathologists, and we process more than 600 kidney biopsies per year, which is quite a lot because we are a small country, and these biopsies come from all over the Netherlands, but also from abroad, such as the Dutch Caribbean.
Joris, do you have slide? You don't have slide because we are not seeing slides. Are you going without slides, or you have slides that you didn't share?
Sharing my screen now.
We don't see the slides. Sorry, if I was interrupting you.
So, well, I already told you this. So we designed a course in diagnostic nephropathology for our trainees. So the Department of Pathology processes more than 600 biopsies per year. And these are not only primary renal diseases, but also transplant cases, pediatric nephrology cases, and consult cases. And we routinely apply electron microscopy to all of these biopsies. And of interest, all our slides are now scanned for digital pathology purposes, which is great for especially teaching and all other kinds of applications. So these are the 3 dedicated nephropathologists that will welcome the students in Amsterdam and that have designed the course. Professor Sandrine Florquin, who is the chief of renal pathology in our center and who could unfortunately not join us this morning. Then to the right we have Dr. Jesper Kers, also dedicated nephropathology and an expert in digital pathology, artificial intelligence, and all kinds of machine learning techniques to study kidney biopsies. So that's really an innovative twist that he is giving to patient care in our department and to our research, and also to the course that we have designed. And myself, I'm the one in the middle. We teach a lot, so we think it's really important to teach clinicians, especially nephrologists in training, the basic principles of nephropathology, and that's exactly what we intend to do in the REMAP part of the N-PATH program. So every year we organize a European renal pathology course. We are ambassadors for nephropathology of the ISN, of course members of the REMAP consortium, an important teaching tool. And apart from that, we have always a lot of fellows who study nephropathology in our department every year. So what will the students learn when they come to Amsterdam? Of course, they will learn the general principles of nephropathology. We will have some instruction on how to handle a kidney biopsy, which special stains are there, including light microscopy, the immune fluorescence technique, which is so vital for diagnostics, and also electron microscopy. And we will cover the entire spectrum of glomerular diseases, both the common ones, think of membranous glomerulopathy, but also the rare ones, think of Alport's disease or immunotectoid glomerulonephritis, just to name a few. We will cover tubulointerstitial disease, and there will be an introduction in transplant pathology and in machine learning approaches. And this will not only be lectures, because it's a hands-on training, so the lectures are interspersed with fully digital hands-on slide sessions. And maybe it's interesting if I quickly show you what this looks like. So I switch to my other screen. I think you can see it. So this is just one of the cases of a few hundred we have digitized and which are available for the students. A case of a It's a pediatric case, so here we have some clinical data, and then the students can look at the biopsy, so they can zoom in, review all the particular aspects of the renal tissue. So you can see how every student can move through the biopsy. And in this case, we see a glomerulus with some inflammatory changes. Then we have the immunofluorescence stainings that go with it. And then finally, we also have some of the electron microscopy pictures, as you can see over here. And after the 3-day course, the students will immediately recognize that this is a case of dense deposit disease. So that's just to give you an impression of how the system works that the students will work with. So that was all. It will be a pleasure to welcome all the nephrologists in training in Amsterdam, if COVID measures allow. So we're now discussing this with our authorities, if it's possible to have this large group in Amsterdam. I hope so, because it will really be worthwhile. So that's my final slide. So thank you very much for your attention. And
thank you, Joris. Thank you very much for your presentation. And now we move. Oh, you have a question. Well, Joris, we have a question.
Professor from Amsterdam. Do you have a nephropathology meeting at the Department of Nephrology? Because I think these kind of meetings are very important for the education of residents of nephrology. Because you have a lot of kidney biopsy, I think it is useful to have this kind of meeting. I'm from Croatia, and every week, at least once, during the week, we have nephropathology meeting, because this is very attractive for residents of nephrology.
yes, indeed, I can only agree with you. It's not only attractive, but I think it's vital to facilitate communication between the clinicians who actually see the patients and the pathologists who see the tissue. So it's of vital importance. And indeed, once a week, we have a clinico-pathological conference where all biopsies are discussed with a lot of physicians who are involved. And if COVID measures allow, we can involve all the students in this conferences as well. So it's a great remark. Thank you very much.
Thank you, Joris. This is what we are calling networking, and the hybrid format will allow us, in making new form of education, and this can be one of them. So we move now from Amsterdam to Prague. Vladimir, let's try again to share your presentation. So it's now your turn. Are you online? Yeah, I can see you. Very well. Please try to share your presentation.
It doesn't seem to work. So I'm sorry, and I would ask Monica to share my presentation instead of me, because I sent the presentation to her.
Well, actually, we see very well. You were able, to share. So go ahead.
Yeah, so I'm here to introduce our General University Hospital in Prague. Next slide. So you see the city, which is still very nice, even during the COVID period. Unfortunately, now almost completely without tourists. Next one. And we are, of course, very proud that we are one of the oldest universities in the Central Europe. We can't compete with Italy, France, or Spain, but we are very old in terms of Germany and Eastern Europe. So our medical faculty exists from 1348. Next. And here you see in what area we are the first. And next one. And we have a long tradition of very important people working in the university, and among many of them, I would stress Christian Doppler, who worked for a relatively long time in the university. And of course, Doppler is also very important for everybody who is interested in the blood flow in arterial venous access or anywhere else. Next one. And to mention some important people who played role in nephrology from our hospital and our university, I would only mention Karol Rokitansky. Next. Next one. Who was a prolific pathologist, performing about 15,000 autopsies, and he also described for the first time polyarteritis nodosa in 1851, 17 years before Kussmaul-Meyer. And here you see the picture from his original publication. Next one. Another important person was Otto Kahler, who was the first one who described nephrotic proteinuria in people with multiple myeloma. Next one. Another one was Bardet-Biedl syndrome, described by Arthur Biedl in Prague in 1922. You know now that Bardet-Biedl syndrome is a kind of kidney cystic disease. Next one. Here, next one. And we were always very much interested in cardionephrology, and here is Otto Klein, who was the first who performed 11 diagnostic catheterization with the measurement of cardiac output using fixed principle in 1929 in Prague, and you see the publication from Münchener Medizinische Wochenschrift. And next one. And Jan Brod, who was the founder of nephrology in Prague, was always interested in the role of kidney in essential hypertension and heart failure. And next. And this group, one member of which was Wilhelm Gams, next one, contributed to the development of what is now known as Swan-Ganz catheter, which is using thermodilution for the measurement of cardiac output. So only this is to show you the long tradition. Next one. And we started chronic dialysis in Prague in 1955 using this very old Alba artificial kidney. Next. And this is a team. Next one. And now coming to our Prague N-PATH team. Here you see me, Dr. Hrušková, who is in charge of the part dedicated to renal biopsies, Professor Malík, who is in charge of the part dedicated to arteriovenous fistulas. Next one. This is the structure of our department. We are working in really large hospital. General University Hospital is now the second largest hospital in the country. We have something like 1,000 beds after many reductions, because we had more than 2,000 30 years ago. And the Department of Nephrology was formed and separated from one of the departments of internal medicine 20 years ago. And currently it has two wards which are mostly dedicated, but not exclusively dedicated, to kidney disease. We have also several beds in an intensive care unit. And we have a large outpatient department and both hemodialysis and peritoneal dialysis unit. Next. And we are, of course, University Hospital Center and Tertiary Referral Center for glomerular diseases and vasculitides. We perform each year something like 250 to 320 biopsies per year of native kidneys. There are no transplant biopsies. These are done in another hospital in Prague. And we have even more patients, because some patients biopsied elsewhere are then referred to us and treated by us. We are permanently involved in pregraduate and postgraduate education. So, for instance, each nephrologist in the country must go through our department. And we are, of course, very much involved in clinical research. And we also have a unit dedicated to experimental research, but this is mostly dedicated to experimental hypertension methods, but also to different models of chronic kidney failure. Our main areas of interest are glomerular diseases, then genetic disease of the kidney. Of course, the most prominent is autosomal dominant polycystic kidney disease. We have in our follow-up several hundreds of patients with autosomal dominant polycystic kidney disease. And the third area are cardiovascular complications of CKD and ESRD. Next. And for a very long time, almost 30 years, we are organizing different registries. We have nationwide registry of renal biopsies, which started in 1994, and we have now data on something like 15,000 renal biopsies. The problem is that these are cross-sectional data, and unfortunately we do not know the follow-up of those patients who were not biopsied in our center. Then we have a special registry of ANCA-associated vasculitis, and we have some local large databases with hundreds of patients with lupus nephritis, membranous nephropathy, IgA nephropathy, and also we of course have many patients with rare kidney diseases such as, for instance, fibrillary glomerulonephritis, C3 glomerulopathy, and so on. For many years, more than 20 years, we perform extensive biobanking. So it means that each patient who is biopsied has his serum, plasma, urine, DNA preserved. And we also want to get some follow-up samples, which is of course much more difficult. We were involved in many genetic studies. We were involved in several GVASs in ANCA vasculitis, IgA nephropathy, membranous nephropathy, and we have international collaboration in many areas, namely in ANCA-associated vasculitis, IgA nephropathy, but also in other glomerular diseases as described. And we were very successfully collaborated with ERA registry when we look at the fate of patients with different glomerular diseases when they are already on dialysis, and we published several papers on that. And we are also involved, as I said, in many clinical trials in ADPKD and also in recommendation for the treatment of patients with ADPKD. And we have been involved also in many investigator-initiated clinical trials. Next one. And now something about the Vascular Access Center and Cardiopulmonary Center. These slides were prepared by Professor Malik. Next one. So you see that this is once again the tertiary center working for the whole country. We perform something like 400 to 450 new arteriovenous accesses surgically created, and almost all which are corrected are done in our hospital. So this is something like 50 per year. And we also perform a large number of dialysis and nutrition catheter and many interventions on fistula, such as 1,000 percutaneous procedures. And also, as the patients are regularly followed, more than 1,000 arteriovenous access ultrasonographies each year. Next one. And this is only to show you how it looks like. Next one. Next one. Next one. And this is ultrasound navigated PTA with Professor Malik himself. Next one. And of course, we are interested not only in arteriovenous fistulas, but we are very much interested also in the heart function in patients with high blood flow fistulas, on heart failure in these patients. So this is another program which is also provided for all centers in the country, and we also publish several papers on that topic. Next one. So what we can suggest and what we can provide to those who will come to Prague is that we can also organize nephropathology seminars, which are regularly done in our center and can be done completely on online basis. And they are, of course, done also in person on a fortnight to 1 month regular basis, but can be done exceptionally when there is somebody coming from other country to visit us on more frequent basis. And we have extensive experience with both biopsies, renal pathology, and also, with, of course, with the treatment of the patients. And there is a similar experience with vascular accesses and any kind of monitoring and care for the vascular accesses. So I'm sorry for the technical problems, and thank you for your attention.
Thank you very much, Vladimir, for this overview on the expertise in Prague. I have a question for you from Croatia. That's right.
Professor Vladimir, thank you very much for your nice lecture. And I have one question. How many kidney biopsy of native kidney you have during the year? Because you showed 300 kidney biopsy. Maybe this is native kidney and maybe transplanted kidney.
No, these are only biopsies of the native kidneys, because we do not perform transplant biopsies in our center, but we are closely collaborating with Institute of Clinical Experimental Medicine in Prague, which performs all renal transplantations in Prague and all transplant biopsies. They have something like 200 renal transplantation per year in this institution, and of course they have many protocol biopsies. So in fact, our nephropathologists, this is one large center, see something like 600 to 700 renal biopsies altogether, and they see also some renal biopsies from other centers for secondary reading. So they have very great experience. They work on the similar basis and NephroPath in US, so they concentrate biopsies from many centers. And what is very nice is that they work on immediate basis. So it means that when we perform biopsy on Friday, we have in the afternoon, we have complete results with the exception of electron microscopy, which comes on Monday or Tuesday. So we are very, very happy with that, because it is very important, especially for the treatment of patients, for instance, with anti-GPM nephritis or ANCA-associated vasculitis. And we also have some collaboration with our nephropathologists on some research topics. We published, for instance, the paper on toll-like receptors in expression in IgA nephropathy, and we have several ongoing projects. For instance, one dedicated to different antigens in membranous nephropathy.
This is really nice that you have the result the same day. This is very important if you have rapid progressive glomerulonephritis. And one more question, who is a nephropathologist in your country? Unfortunately, I don't know, but I am interested.
Most experienced nephropathologist who is currently also involved in some activities of International Society of Nephrology is Eva Honsová, but she recently retired from the Institute of Clinical and Experimental Medicine and from the medical faculty. And currently the person in charge of the center is Dr. Voska. And our main collaborator is young nephropathologist, Dr. Kolar, who is really excellent. But as I said, there are 6 or 7 nephropathologists in the center. So this is very good, because they can replace one another and they really work on permanent basis.
Thank you, Vladimir, once again for your presentation. 6-7 nephropathologists is a huge number, since there is a shortage worldwide regarding renal pathology. So this is a very good starting point. And so we should, all of us work in this direction. In my institution, we have 2 nephropathologists, but in Italy there is a shortage of them. So for this reason, we needed to train, a new fellow. So we move now from Prague to Barcelona, and I asked to Professor Ibeas to give us an overview of his institution, Parc Taulí.
Thank you. Thank you very much. Thank you very much, Professor Gesualdo. I would like to congratulate you for this fantastic meeting, and mainly for going through the totally online meetings to the first hybrid meetings. Well, I would like now to introduce my center. I'm José Beas. I'm a nephrologist. I work in the Parc Taulí University Hospital in Barcelona. And in NephroPath, our main fields of interest is vascular access, ultrasound, and in some conditions also we can work in PD. Well, this is our center. It's a lot of buildings. This is in a schedule. This is the main building. This is the chronic hemodialysis unit. So our main activity, although these are the research centers, the centers of radiology, another kind of centers with different activities, our acute units, emergency room, interventional radiology suite, OR, and so on in this main building. Here we have our chronic hemodialysis unit with more than 150 patients. We are involved in a lot of research projects from a national point of view or international point of view. And our activity of our hospital, we have about 700 beds. Our population was about 500,000 inhabitants, but 100,000 had been sent to other hospitals in order to receive more complex pathology. And this is our usual activity, more than 200 patients in research and training and so on. We have different areas of research in our center, and our research and innovation group that is called Clinical Interventional and Computational Nephrology is based mainly not only in clinics but also interventional procedures and in bioengineering. In fact, we are working a lot with artificial intelligence and biomedical engineering procedures. And in fact, we have created a mixed unit with the School of Engineering at Autonomous University of Barcelona. This is all the people that are involved in our group, and mainly I would like to highlight the incorporation of biomedical engineers. In relation with vascular access, this is a part of our team, of all specialties, and all the knowledge that came from here goes to clinical practice. We have these kind of centers, an acute and chronic hemodialysis units, 35 hemodialysis monitors, about 200 patients with chronic kidney disease, most of them in hemodialysis, and our vascular surgery department has a reference area for close to 1 million inhabitants. Well, our vascular access program is based in I would like to highlight, in a multidisciplinary team, each team coordinated by the responsible in order to have the coordination of all the activities, not only assistance, but also investigation and innovation. Our healthcare infrastructures joins on not only IR or OR, but also follow-up of patients' clinics with vascular surgeon joined with the nephrologist and ultrasound in the middle to use the high resolutions of patients' clinics program in order to take decisions as soon as possible with the multidisciplinary knowledge. We have training programs, research, innovation, and so on, always try to be based not only from the point of view of the patient nephrologist, but always from a point of view of multidisciplinary approach. And this is crucial in these kinds of programs. Well, we have a lot of opinion in training. For the last 15 years, we have made over more than 40 courses. These kind of courses are based with simulation models, with patients, with also animal models. We are close to the University of Barcelona, Autonomous University of Barcelona. We work with animals with the vet school, and we use the infrastructure in order to work on live with animals, mainly pigs, in order to put tunnel catheter, PD cats, kidney biopsy, and so on. Well, our training program allows us not only to receive all the residents from Spain, but also residents from South America and Portugal, and even customized programs for people that want to come to learn us or related with our program. And always thinking that we cover all the areas related with the follow-up of those classes from the creation to the follow-up, reconstruction, and so on. So, in summary, I would like to highlight that our center had become one of the reference centers in Catalonia for vascular access, and became in teaching one of the reference centers internationally, mainly in Europe. Our multidisciplinary approach, I think, is the core of our program, because although we need to teach our residents in nephrology, we need the knowledge of all the specialties that work with us. All the several lines that we have investigation related with these previous comments. Well, our role in the organization of the project is related with the REVAC and the REMOS. We're going to prepare the lectures, the learning programs, and so on, and all related with the training, with hands-on programs, in order that our residents acquire the best knowledge in this field. Well, this is our team. They are nephrology, vascular surgeon, radiologists, and nurses. We never should forget the role of the nurses, because he is who is closer to the patient and detect the problems. And in this way, finally, we have to conclude that probably this kind of programs, I would like to congratulate again to Dr. Professor Gesualdo, is probably the future of medicine, not only by the role of the nephrologists, but the role of all the specialists and all the European Commission, and this couple of societies, the Vascular Society and the European Society of Nephrology, in order to arrive to the best aims. Well, thank you very much, Professor Gesualdo.
Thank you very much, José, Professor Ibeas, for this overview regarding Barcelona. I had the possibility to visit your place, and I was very impressed by the facilities that you have over there, and actually also the people that are very trained on the educational program. So we move now from Barcelona to Milan, and I invited here Professor Gallieni, Maurizio, that will present. Gallieni.
Thank you, Tino. Thank you to everybody in the room and the people also attending online. I want to thank the European Renal Association for organizing this multiplier event and getting together physically, finally, at least with some of you. This is a dream come true because training fellows in interventional nephrology is very important, as Professor Gesualdo outlined in the first lecture that he gave. And actually meeting Tino, I want really to praise Tino because his volcanic mind actually came up with the idea of the N-PATH project. So he called me and we kind of shaped it together, and I'm glad that many of the friends and people I've been collaborating with in the past few years are within this project. And Tino, thank you, because not only you have good ideas, but also you have the ability to get to the target and having this meeting and this project ongoing. I will take a few minutes to present our own institution, if I can have my slides. I am from the University of Milano, and indeed I have been an interventional nephrologist since I was a medical student, because at that time my director, Professor Brancaccio, was actively doing AV access surgery, so in the dialysis unit, and at a certain point he asked me to start putting venous catheters. And as often comes from failures, good things come out. I remember a very good patient of mine. I had a special relationship with her, so I tried to put this central venous catheter and I could not make it. I just failed after several attempts. And then the following day, with the help of an anesthesiologist, we could place the catheter. But from that moment, I went back to Professor Brancaccio and I told him, Diego, I'm not doing this anymore because it was too stressful. The only way we can do it is that if we buy an ultrasound, a portable ultrasound that I saw in a meeting that was at the EDTA meeting, actually, by the way, in Glasgow, 1993. So he said, okay, I will buy that. So we imported the first site right. I translated the manual, and then it went into the market in Italy. So I think I'm the first nephrologist in Italy that put an ultrasound-guided catheter. And from that point on, I was very interested in developing training, because I had to do it myself, everything. And so then I met VAS, the Vascular Access Society, which is also part of this N-PATH project, that at the time was mostly made by surgeons. And so I met a lot of friends, and I've been the president of VAS, the same thing that Jose, who is standing by me right now, is also being a past president now. And this is the root from where this project are coming from. So what is our university? It's located in Milan, in northern Italy. We have outstanding things, among them the Last Supper by Leonardo. This is a channel in Navigli, Milan, that was also built by Leonardo in the 14th century and is still active. This is the website of the School of Medicine at the University of Milan. It's a very big institution with 8 departments, and I work in one of these 8 departments. Overall, there are 600 professors at the School of Medicine and researchers. and it's one of the biggest in the country. And each year we welcome about 3,000 new students in the medical school for medicine and related educational programs. This is a slide for the fellows who are listening to us. Within the website of the university, you can find a lot of information. This is just an example also on discovering the city, so who will be part of our own hands-on training sessions can take a look at the website for more information. What are the N-PATH activities that we'll have in Milan? They will be mainly based in our own department, which is working in 2 hospitals. One is the Sacco Hospital and the other one is the Fate Bene Fratelli Hospital. This is the website of the department, and in this picture you can see our facilities. In the background it's the research building, and in the front it's the place where the library and the sessions for the lectures are usually undergoing for the medical school. So in the map of the city, you see that with the blue pin is the place of Sacco Hospital. It's kind of on the border of the city, while the red pin is the Fate Bene Fratelli Hospital in the very center. And I also added with the black pin the Department of Physics, because with them we are actually developing hands-on training simulators, and it is possible that during the hands-on training sessions in Milan, we will also visit the Department of Physics. So what is the role within the N-PATH project that our center will be providing? In the work package 3, in the implementation, in particular, we will be part of the REMAP programs, which is the first one that we are going to have in November for the simulation training of renal biopsies. And then we will be involved with the REVAC for vascular access and the REPED for peritoneal placement. So we will have 3 hands-on sessions in Milan. And of course, we want to be active part of Work Package 6 on dissemination exploitation, which is very important as well, so that this project will be the first step towards a long-term activity on the training of renal fellows in interventional nephrology. Professor Gesualdo already showed this slide. This is our goal, to blend the online and face-to-face learning with the hands-on training and web lectures. Regarding training, I want to show a couple of slides. This is a publication that was done with Professor Vertemati. This is the cover of the journal Clinical Anatomy. It was published in 2020, and in the cover there is one of our 3-dimensional reconstruction of left brachiocephalic vein. The idea of this paper was just to demonstrate how tortuous the path of the vein is, and it's not something that you can realize when you put a catheter from the left side, how difficult it can be to just put down a dilator or a guide wire. And this is the same reconstruction with also the heart and how the veins are connected and related to each other. And we are also developing original technology for 3D reconstruction and visualizations. And this is just a slide, just to kind of an appetizer of what we will try to show you today with my colleagues and researchers, Simone and Sebastiano, who will be in the room today just to do some demonstration of what we are doing. And that was I think my last slide, or maybe there was a picture of what we do with our fellows, and a last picture. I think this represents Milan. It's an advertisement, but I think the powerful people that live in our city are very good, very well expressed by this picture that I took last winter. And to all the fellows that will be in Milan, we are looking forward to meet them. Thank you.
Thank you, Maurizio, for the overview of Milan Center. And we move from Milan to Ljubljana. So, and I ask to Professor Butorovic Ponikvar to give her presentation.
Okay, great. So I'm pleased and honored to be here with you today. My name is Micha Arnold, and I'm collaborating with Jadranka in this REMAP Renal Expert in Molecular Pathology, Model 1, of course, which will be focused in our center in the expertise in kidney biopsy. So in the introduction, let me say that there is no nephrology without nephropathology, and there is no nephropathology without percutaneous kidney biopsy. You can probably all agree with me. And I may say that percutaneous kidney biopsy is an integral part of nephrology clinical practice for many decades now. However, in many countries over the past decades, this procedure was transitioned from nephrologist, as you may know, to interventional radiologist in many parts, not only in the Europe, but also specifically in the US. And I believe strongly that REMAP course will teach young nephrologists in the state-of-the-art nephropathology and train them in kidney biopsy, which I believe is a fundamental invasive procedure for our profession. And we expect that our young nephrologists will nurture and further develop this knowledge and skills of these procedures for the benefit, of course, for our patients and nephrology in general. And this is our University Medical Center in Ljubljana, which is quite a big hospital, more than 8,500 employees. But sorry, I will focus on our nephrology department, which includes 200 employees, 23 licensed nephrologists, and actually we are quite sexy for our nephrology fellows. We actually have on board 18 nephrology fellows and also one young basic science researcher for the translation and medicine research. We have several habilitated teachers, including full professors, associate professors, and assistant professor, more than 10 PhD students. And we are actually quite a large unit in our center. We have 7 in and outpatient units. Our in-hospital units encompass 32 beds, including regular and transplant department. We have 2 hemodialysis centers with more than 230 patients, then center for peritoneal dialysis, and also center for kidney transplantation. And we actually take care for the complete national cohort of our transplanted patients. And we are happy that we actually own our own ultrasonography unit, where we also perform our biopsy procedures. And on a yearly basis, we perform around 300 native and kidney transplant biopsy procedures per year. So we actually perform, as already mentioned, all these procedures in real time under ultrasound guidance by a single operated, which is nephrologist. And I think this should be the standard of practice in large and good nephrology centers across Europe. So this is a brief review of this hands-on training with the tutors in this renal biopsy. As you can see, in 4 university hospitals in Bari, in Sacco, in Milan, then in Ljubljana and in Prague. I think each center will host 10 trainees. Here are the tutors, and then I think more or less all these trainings will be held during the November. And then after this training, the students will meet in Amsterdam for 3 days and for the digital pathology seminar. And we've heard about this session in the previous talk. So here is the brief overview of this hands-on training in kidney biopsy with the associated topic, and this will cover some theory, and then our students will be present in the operating room with real patients, and of course we will review the procedure with some recorded videos. And of course, we will be using some teaching aids, which were already introduced in the previous talk, such as the augmented reality simulator and renal biopsy simulator. Our students will then learn how the biopsy cores are processed, and then on the renal ultrasound follow-up and possible complications after the biopsy procedure. So here is a day-to-day schedule. I don't want to go deeply into that. This will be a 4-day course in these 4 centers, including our own. And I'm very happy we just received one of these Blue Phantom training models, and we are training ourselves on it right now to get familiar with this. And this is even more important. This is the VR simulator we already introduced in the previous talk, which allows to perform interactive kidney biopsy in the virtual reality environment. We are still awaiting for this simulator. I think it's coming at the end of this month, and we are really happy to get familiar with this, I think, very interesting learning aid. So our clinical center have more than 30 years of clinical experience in performing native and transplanted kidney biopsies. Also expertise in comprehensive kidney and renal vascular Doppler ultrasonography. And we know that today kidney biopsies are performed in more and more complex patients than ever before. Let's say in the very elderly with many comorbidities, limited cooperation. Patients were taking anti-aggregating or anticoagulant therapy with acute and chronic kidney disease, sometimes solitary kidneys, and multiple cysts. So safety is priority, and this actually demands expertise in renal Doppler ultrasonography with good equipment and instruments. And I think, and this is also our practice, we use this dissection microscopy in real time because to assess sample cruelty, usually after each needle pass, and then to adjust based on this information the needle size to reach sufficient sample cruelty, of course, while maintaining maximal safety. And this is our routine clinical path with checklist that we use in a day-to-day clinical practice for all our biopsy procedure in and outpatient. And we use this information to ensure quality and safety for every procedure on kidney biopsy. And we will share this information also in the English language for our students. And this is our dissecting microscopy. We actually own one of these in our ultrasound and biopsy room. And as already told, sample is evaluated after each needle pass. And if active bleeding is observed after the first needle pass, then operator discuss this with our technician. If sample is insufficient, and if molecular diagnostic is planned, we do a lot of molecular diagnostic this way, specifically in kidney transplant biopsies, then we adjust further procedures according to real-time information. I think this is very important. And of course, at the end, I would like to say to welcome you at the REMAP in Ljubljana, Slovenia. And let's bring kidney biopsy back to nephrology, I may say. And I strongly believe that no one can do it better than ourselves. Thank you very much for your attention.
Thank you, Dr. Arnold. Thank you very much for your presentation, your overview of Ljubljana. And regarding this point, there was, a participant asking regarding the hands-on training in Bari. And since, we are getting, all the materials Dr. Arnold was reporting also for Ljubljana, we will have the hands-on training at the beginning of December. So I hope that I have answered to the question. If there are other questions, please use the chat. You can write in. Dr. Arnold, there is a question coming from Croatia once again.
Thank you very much. How many kidney biopsy of native kidney do you have per year, please?
Approximately 100 transplanted kidney, more or less.
Is Nika, but I don't know her last name in Ljubljana.
Pathologists, they are Nika Coates and Maya Freilich. We have two dedicated pathologists which are reading our native untransplanted kidney biopsy, and they both learned from Dusan Verluga. He's a well-known pathologist, as you may know. And now we have his...
Okay.
Thank you, Mia. And now it's time for moving from the university to the European Society, and I ask to Monica Fontana to present ERA, European Renal Association.
So thank you very much. Welcome everybody that is here in person to Parma. It's been fantastic to start seeing everybody in person, and a very warm welcome also to all our participants that are attending virtually. Let me first thank my collaborators. So ERA, the European Renal Association, is hosting this. We are very proud and very grateful to Professor Loreto Gesualdo, Tino, who without his energy, this has already been said before, we would not even be here. So let's give the nephrology world back what the nephrology world should have in the first place. I speak by mind, and so I apologize for this, but I think this is a great and incredible initiative. I would also like to thank Professor Gesualdo's team, in particular Dr. Giusto. He has been instrumental in supporting us also throughout this. Least but not last, Laura Azzolini, our marketing and communication manager, and also my personal assistant, Moni, who's in the back and who's been supporting us very much for this meeting. So I have a few slides to present. And so we are the European Renal Association, former ERA DTA. I am Monica Fontana, I'm the Executive Director. Next slide, please. Okay. So everybody knows the European Renal Association. We were founded in 1963. We have over 6,000 members, mainly in Europe, but in reality all over the world. We organize the most important nephrology congress in Europe, and by numbers, the second largest worldwide. We publish 2 journals, Nephrology Dialysis Transplantation and CKJ, Clinical Kidney Journal. We have a registry. This has already been mentioned during this meeting. We collect we collect data from dialysis centers for very important epidemiological studies, and I'd like to underline that we have the biggest research center in Amsterdam. This is where the registry is based for pediatric nephrology. We also have fellowship programs, research and education programs, and that is why we are here today, because this is our core activity. It's one of the aims of the European Renal Association. We have 8 working groups and various committees. So what is the role of ERA in this incredible journey? Because I think it is a journey. Mainly dissemination and exploitation, but also quality assurance, implementation, preparation, coordination. I will go very quickly through a short timeline. As you can see, some of these items have already been put in place. There are more details. I'd like to also outline that many of these packages are done in collaboration with the Vascular Access Society. We are the main societies that are coordinating the dissemination, communication, and exploitation plan. You can see the different steps that we are involved in, and in particular, I'd like to highlight, apart from this meeting, the first kickoff meeting officially was done, unfortunately not in Bari. We were not able to do this due to the pandemic, but this was done regularly. So I'd like to underline that notwithstanding difficulties, we've been on track. And this is thanks to the very, very hard work of all parties involved. We also are having today this meeting. We are very grateful that all the 40 participants that will be putting their hands in practice to make this, to enlarge their own personal CV, but hopefully this will then expand and become the norm in a few years for nephrology training. So we're very happy to have them on board during this meeting. We also, however, will use ERA, in particular our Congress, to give updates on N-PATH. We do not want this to stop. We want to keep people informed of how things are going, the new technologies that we have already seen, the new instruments that we will be having during this course. In particular, we will have a session organized in our Paris next year at our Congress, and one in Milano in 2023, as we have already done at the Congress this year as well. I think this is my last slide. I will be very short, and then I think the Vascular Access Society will be giving their presentation. So this is just another administrative point because these are things that we need to do. Most of them have already been implemented. So please do become, share on Twitter, let's say, activate your Twitter account, make sure you're one of the N-PATH, let's say, use Twitter to promote N-PATH. YouTube as well. Make sure that all your colleagues know about this and spread the voice. Thank you very much.
Thank you very much, Monica, for all your support and for your team. And now it's time for the VAS Society, the Vascular Access Society. And we have online Professor Shemesh from Israel.
Yeah, thank you, everybody. Welcome to the Vascular Access Society. I am David Shemesh, the current president of VAS, and I will briefly present VAS. Our objectives are to raise interest in the field of hemodialysis access, to promote and conduct basic and clinical research, and to organize congresses, meetings, and courses. The Vascular Access Society, VAS, was founded on October 1997 in Maastricht, the Netherlands. VAS is a multidisciplinary society which is of interest to nephrologists, surgeons, interventional radiologists, dialysis nurses, vascular and radiological technologists. VAS is the leading international vascular access society. It is involved in various types of education, practicing, and scientific exchange in this field. VAS organizes an international congress every 2 years in one of the countries in Europe. Every other year, at least one vascular access course will be held in a European city. The multidisciplinary council of the VAS consists of nephrologists, surgeons, and radiologists. Representatives from each European countries will be asked to join the board. The board members are your humble servant, David Shemesh, Jose Beas, Joyce Rothman, Nick Inston, Tamara Jemkov, and Matteo Tozzi as the council representative in the board. We have a long list of council members from different countries in Europe that take crucial part in the committee's activities. There are 9 committees. The Research Committee, led by Joyce Rothmans, the Education Committee, and eventually the N-PATH Committee dedicated to the N-PATH project. Last but not least is the Journal Vascular Access Committee, led by Jan Tordwar, the JVA editor. We have collaboration with several societies around the world, from Europe to the Vascular Access Society of the America, and from Asia, for example, the Japanese Society of Dialysis Access and others. We have also chapters and associations with other countries around the globe, as you can see in this list. These are the members of the research committee led by Dr. Joyce Rothman. VAS is a small society. Thus, the budget of VAS is limited for research, and Joyce is looking for cooperation with ERA and ESVS, as you probably know, in order to raise the grant allowing large-scale studies. But the goal of Joyce is to set up a network of European research countries, centers with expertise in vascular access, and we are working on that right now. This is the education committee that produce educational material for the members of VAS, but also to share our knowledge with all those who have passion to vascular access. We have an open library of videos covering surgical and endovascular approaches. We also share handbooks available for download, literature monitors, and recent guidelines of vascular access guidelines. We also started doing webinars, and this is the last one, with near to 500 registrants, and its recording is available to all for free at our website. Education is the most important thing for VAS. In 5 days, we had 250 viewers, which is quite good for a small niche like the vascular access. As I mentioned before, we share with other societies the journal Vascular Access. Many manuscripts were published during the last 10 years in JVA, and the current impact factor is 2.2. In April this year, we had the VAS 2021 virtual congress in Berlin in the middle of the third COVID-19 wave, and it was a real success in spite of the COVID-19 pandemic. The next Congress meetings are in Oporto 2023, and after that in Venice 2025. But we also plan a VAS course in Tel Aviv, and we're deeply involved in the EVC courses in Maastricht. And this is a taste of Porto and of Venice, Italy. You are kindly invited to join these congresses. I am sure it will be a success like usual. We are ready to plan and perform our 2 multiplier events and to support this project as much as we can. We have several options where and when those events will take place, and we will discuss it soon in our upcoming N-PATH committee meeting. We will perform these events in our best way according to the N-PATH protocol. Thank you for your attention.
Thank you very much, Professor Semes, for this overview, and thank you for the support that also the Vascular Access Society will give to N-PATH, and we have also the past president here with us, Professor Ibeas. So we are on time, 11:30, so it's Swiss time. And I have my last presentation before the coffee break. Thank you, the slides are already on. I would like only to present my center before I go with the N-PATH class. Barry will participate in N-PATH program with the 4 curricula. So we cover everything because we were lucky that we just opened up the new Institute of Nephrology, is 6,000 meters square on 7 floors that covers from the inpatient to the outpatient, that we have 24 beds. 4 beds are in intensive care unit for nephrological patients. We have an outpatient service following more than 6,000 patients with GN, diabetes and hypertension, 1,600 renal transplant patients, We perform in our institution around 200 biopsy per year, but our renal immunopathology center is reading more than 400 biopsy per year. And we have a surgical room, a theater devoted to the interventional nephrology for renal biopsy, for vascular access, endovascular procedures, PD insertion, and we have a huge ultrasound service, plus a PD program, more than 100 patients on PD, and an HHD service. We have also a simulator center that will be used during the training. And so this is our facility, and we are, waiting to welcome you in Bari. Bari is a city on the sea where there is very good food. Fish is our specialty. So this is Bari facility and facilities, and now I go with the last presentation, and that is, the core of, the presentation that we are having as is the presentation of the class. Can I have the slide, please? Thank you. And we closed the call in at the end of June, and we selected the participant between July and August, and we were very excited and very pleased because there were many applications, and I would like, to summarize for you what has been done during these months. So the admission, the admission criteria were, to enroll the first and second year residents in nephrology, according to candidates' country residency program regulation. The N-PATH, as I told you, as a complementary training path to the residency program, so is on the top on what, the resident is already doing in his program. And what, the N-PATH will offer to residents will be to create an international network among them, foster the exchange of good practices and knowledge, acquire transversal and multidisciplinary skills, and to practice with key specialists in nephrology at the European level that were introduced to you this morning. 87 total application. We received 87 from 24 countries. So you can appreciate the country are reported here: Armenia, Belgium, Bolivia, Brazil, Chile, Cuba, Czech Republic, Ecuador, Egypt. So many, we were very pleased, Dr. Fontana, to see that there was so much interest in our program. Unfortunately, some application we selected only 48 applications on the base of the criteria. So we were not able to accomplish all of them. And the 48 selected application, the candidates underwent an interview, and from an international board that was composed on the N-PATH steering committee members, and the average age of the residents that were selected is 20 now. Very, very young resident. 8 residents out of 48 were, unfortunately, they didn't get in, but they will have the possibility to stay in the e-learning platform during these 2 years. They will not do the hands-on training. And as you can see, 31 of the fellow are females and 9 are males. So, the females is, nephrology is pink. And regarding the final step, this is the final selection. The 40 residents belong to 13 countries, and they are listed here from Belgium, Cuba, Greece, Honduras, Portugal, Slovenia, Spain, and so on. So thank you and welcome to the N-PATH class. Now is the more practical part. So we will have two presentations, one from Valentina and Valentina Bocchi-Bianchi that will present the e-learning platform, and another one from Marta Baratto that will present the N-PATH training simulation. But before I give the words to Valentina, I would like to introduce our quality control steering committee. The head of this quality control is Dr. Alberto Mandoli. That is, he will introduce himself actually.
Yes, I am introducing myself to you. My name is Alberto Mandoli. I am a medical doctor, but in this case I am the head of the Quality Control Committee of N-PATH. I will introduce my colleague, is Dr. Valentina Bocchi-Bianchi, that show you the function of the e-learning platform that will be the backbone of the e-learning during the 4 courses. I don't want to tell too much words, but I want to underline that N-PATH is a path, is a journey that, like Monica has told before. So N is nephrology, but is an opportunity for everyone to have a new kind of educational mode. Valentina, I pray you to show in which way Erica, that is one of the small company that make part of the consortium that provide, that deliver the e-learning platform. Valentina?
Thank you. Is it open the mic? Yes, yes, it is. Okay, thank you so much, Alberto. Thank you to all of you. Yes, I'm Valentina Bocchi-Bianchi. I represent Erica, and with my speech is about how the N-PATH e-learning platform works. So everything starts from the website npath.eu. Just click into classes. You access to the e-learning section of the site. So all the residents has already their credentials, so just put this one. Okay. So Renzo, who is our resident, he's not real, Renzo Tramaglino. So our resident just enter in his dashboard. His dashboard is his personal profile, where he could find the 4 courses, the calendar, where the web events are, and his profile, which could be edited. So go back to courses. Of course, at the moment, you can join only the REMAP one, because REVAC REMUS will be available starting from 2022, and REPAD, should I do something? No. And REPAD starting from 2023. So we see the progress here, but we dive in REMAP so I can explain you better. Okay, upon entering the course, the resident get the first informations and a summary of the activities that REMAP have. Okay, so number 1 are the lessons. So we receive from all the teachers so different files. We receive PowerPoint slides, video lessons, different attachment, PDF, and I want to show you a couple of these. So we can start with Professor Arnold. As you can see, he prepares some slides, and each file has been elaborated by our graphic department. The images has been vectorized, the tables rewritten, all the tests being remodeled, everything to do such a very readable and enjoyable lesson. So we have the annex. For example, this is about the ultrasound guided biopsy. I go quick, just to show you that we have different attached annex. Okay, and we have also some PDF that the resident can download, and the lesson slides. Okay, so the slides that can be printable, can be print. Okay, that's it. We have reached also video lesson, like this one of Professor Florcan. Okay, here again we have do a very massive work on the images. Okay, I go quick. Well, when the student has reached, okay, we reached the 100% of the progression of each lesson. I'll show you that, okay. And download all the annex. The progress goes to 100%. And it builds up the whole progress. So we have still one lesson to view. It is this one. Okay, we have to see all the lesson. So I go quick, but you don't have to. Okay, so we have 100% here. Also this one. Okay. And once you have downloaded all the, see all the annex, okay, 100% here. Perfect. So now we have, no, sorry, we have one more to see. Oh, I think it's Professor Sauerbrunn. Here we are, here another video lesson that Professor Sauerbrunn made on renal imaging. Yes. Okay, so the student has the 100% of the progress. We didn't, because I didn't download the slides. Now we have. I still missing one.
Study very well.
Yes, it's true. I didn't.
So you cannot skip.
You cannot cheat. You cannot cheat. That's it. Okay, so all on 100% now. I think there is something missing still. So yes, resident, you have to watch all the lessons. 100, 100, 100, 100. Still something missing. Okay. What happened? The REMAP test unlocked. So, can you help me to make this test? Which one of the following statements about kidney biopsy is true? Which one? I'm testing you. The first one, okay. And the second question is about the common complication after kidney biopsy include.
So the second one should be.
Okay. So once the the quiz has been completed and passed. Okay, correct, great. The second, you passed it. So the second law containing the evaluation form that Erasmus Plus required us for reporting can be completed as well. So okay, I don't have to do it. And that was the classes and so the lessons. Then number 2 is about the hands-on training. Here are all the information about hands-on training. Obviously, every resident has already been warned about where he will go, but here we have, all the information about. Again, once the hands-on will be held, the student can make a survey. He will answer to some questions that we need to know about how pleasure has been his hands-on training. And last one, in addition to all these activities, we have organized 3 appointments called Meet the Expert, which is an opportunity to meet professor and discuss the topics of the lesson together. It will be a Zoom meeting and will last about 1 hour, 1 hour and a half. Professor Gesualdo, who is the principal investigator of the REMAP course, has divided the module in 3 macro topics which are this one, biopsy and ultrasound, digital renal pathology, and system biology and renal biopsy. And yes, we have already set the first one, which will be the 25th of October. And the resident to enjoy just have to enter here or from his dashboard to the calendar, and he will go directly to to the course and to the video. Just clicking here the same day of the Meet the Expert event, he will join this meeting. So that's it. If there are no questions, thanks you so much for the opportunity.
Let's see if there are questions from
of course.
The participant online. I don't know if there are questions regarding the platform here or from. There are some questions coming in? No. So you were very clear at this point. And it's time that we move from the e-learning platform to Marta, who is Marta Baratto, that will introduce the platform practice. You go on the microphone with the computer or you don't need the computer? No, I don't need it. So we can, shut down that microphone that is close to the computer and we go with this one.
Okay, good morning, everybody, here and online. Is it still on? No?
This is the computer.
Yes. Okay. Okay, that's it. Okay. So I'm Marta Baratto. I work for EMAC, and our role in this beautiful project is to take care of the hands-on training. So EMAC is a small, medium enterprise that is working in the healthcare sector for more than 40 years. And what we find out and learned in all these years is that technology can really improve the quality of life of people who are dealing with healthcare, patients and healthcare operators, because it's important that both can work well. We truly believe that simulation is a very crucial part for learning and supporting new doctors and already doctors that can retrain themselves on procedures that they're not so familiar with. So along the years, we find out different technologies that can be supported in this kind of trainings. So we are very, very proud to be on board in this project. And our job actually here was very easy because we are actually, let's say, a technology scouting company. And we had all the best already with us. Because in the partnership, the people that are already in the project, they are really the edge of people working on these topics. So I will not talk anymore, and I will give all the people a sort of a glance of what they will find out during the hands-on training. So I invite here Professor Gallieni and his team to give a short presentation of a virtual system that will be used for the REMAP product, REMAP module, and after all, we will go through other kind of physical simulations. So I hand over the word to more expert than me.
I take only 1 minute to present two very young and outstanding young men that work with us in the development of the hands-on training that we will have at the University of Milano. Simone Cassin is a medical doctor who has his doctoral thesis of medicine on this subject and is now in the fellowship of orthopedics and is also working during this fellowship on simulation training. And Sebastiano Panfili is a bioengineer, so they are strict collaborators of Professor Maurizio Vertemati, who is professor of anatomy at the University of Milan and who is part of our own project. So I will hand over the microphone to Simone for the rest of our presentation.
Thank you, Professor Galdieni. Thank you, Magda, for this opportunity. And today we are going to give you a short demo of one of the technologies we've developed. We are both research fellows from the University of Milan, and we are working on a research project funded by the EU that's called PrintMed 3D. And in this project, we aim to create an integrated platform for three-dimensional technologies in medicine. One of the technologies is about virtual reality, and now Sebastiano will talk to you something about that.
Hello to everyone. As Simone said, we created a new environment, a 3D virtual environment, where it became possible to do what is not possible to do in the real world. Can we have the slide, please? Yes. Next. Okay, thank you. Next one, okay. The starting point of this process are the medical imaging that allow us to do the so-called segmentation process. You will see it in the following slide. This one. Then we use semi-automatic algorithms and in-house developed codes to reconstruct a 3D model and to load it into the virtual reality environment. That is an application. One thing to remark is that all the images, all the medical images used are from a specific patient. We load the models in the virtual reality, and what is possible to do in our application is to explore the model, as you can see in the video, to zoom into details, to see the model from any point of view, any angles, and to see through the skin at the anatomical features of interest. The result of all this process, the result of all this workflow is what you will have the possibility to experience right now, today.
Thank you, Sebastiano, for this short presentation. So I will recap what are the key points of our technology. First of all, we use only patient-specific 3D models. So we reconstruct everything from CT and MRI scans. So nothing is invented. The technology we use, the immersive virtual reality, allows the user a high level of involvement, and it gives the possibility to train in a safe environment. All of this is available at a very low cost, and because of the device we are using, it's highly portable. I thank you again for this space, and now we'll go on with the demo. I will invite you here with us to try the system, and I also invite you to visit our website, www.printmeds-3d.com. Thank you.
So, who wants to try? It's time to try. I want to try. You were sure, right? So now for the residents that are on the other side. So what you can do, you can build up your, immersive reality to see. I saw that you choose a kidney with cyst.
Yes.
So so if now you needed to do renal biopsy, you know where is your kidney, how your kidney looks. So you can also choose the best space where to go with the needle, if I understood well, or not.
If you consider the possibility of a patient with a single kidney, for example, and with a cyst, so in that case, in a very specific case,
You should come here, otherwise they who is online will not understand our discussion. So the discussion is, we can reproduce what is reality, so the kidney, how the kidney looks, and from the images that you can import from the CT scan, you can have the right image of your kidney. So if the kidney has cyst or have other, abnormalities, you can very well appreciate them before you go in the reality with the renal biopsy.
Correct.
Did I get it well, the point?
So the point is that not only educational, because of course we can use this technology for
risk management,
but also for direct medical activities like surgery. And in the case of kidney biopsy, of course, you would not use in all cases, but a very difficult case, you can do a CT scan, reconstruct a single kidney with the cysts, and then you can have it with the 3D visualization, and you can also print the kidney. So we have the 3D printing, so you can see how the kidney is and be prepared to the biopsy. So that's, maybe Simone can tell us about surgery, because they are doing surgeries in children with this technology.
But before, we give, the mic to Simone, what, Arnold was saying, Arnold was saying that, the phenotype today that undergo biopsy are, different from the past, that were, more young. Now, the patient are, older, sometimes they get many cysts, and you needed sometimes to decide to go to the right, to the left, if you needed to go to the upper pole or the lower pole. So having an image reconstructed 3D in this way will help, the nephrologist in doing the biopsy. So thank you very much for this opportunity. So for the residents that are, on live, this will be a very good opportunity, because actually we will try also to share this kind of technology in the 4, sites. We will see what happened. So Simone, do you want to add something on?
Yes, I just want to add that we are using this technology in a variety of fields. We are using it in education to teach patient-specific anatomy to the first-year students of medicine. And we are also using this for preoperative planning, for example, as Professor Gallieni said, in pediatric surgery with Professor Gloria Pelizzo of Milan. And this has been an extremely successful experience for us, and we are still working on to improve this technology day by day better. as possible. Thank you.
Thank you, Simone. And for all of you that are online, I will try, the device. I will let you know how it looks. But maybe you will see me on the screen, right? Or not? I will go with this.
Yes. Just give me a minute because I have prepared the device to start the application.
We are preparing, to do it. Immersive reality and
you have to come here with me.
can we see on the screen what we are doing? Not.
On the screen, no.
So you should trust me. I will try to report what I see inside of the glasses, on the virtual glasses. Oh, okay. I'm sorry. I didn't know that. So because we are also, this is also nice regarding networking, because we will have also new devices that are still, patent pending. So
I will explain you how it works. So
yeah.
This okay, thank you. This function as a click, as in the mouse, so you can select what to view, and
Zoom a little bit. In this way, they can see better.
okay, and you can select what you want to see, and you can view the model, rotate the model, and zoom in with the joystick. So click and go on for zooming in or zooming out. That's all. It's very simple but very useful.
Okay. Thank you. You want that I try now?
Yes.
Okay, let's
if you
try.
want, yes.
I tried the same. It looks almost very close on what. This is also nice, networking. We can compare technology. I saw what Professor Ibeas in Spain, in Barcelona, developed that is almost close to this technology. Let's see.
So this is the controller. You have to use the real button to click and select the model.
The real button.
This one with the index finger, and you can select, for example, one of the two models. Then you can click on view on the bottom. Okay, and now if you continuing pressing the button, you can rotate the model. So, no, you have to view on the right and up, move your hand.
Okay.
Yes, and now you can see the full model in front of you.
Very nice.
And you can rotate.
You should trust me. It's very easy to do it. I can see the kidney. I can see the spleen. And now I rotate on the other side. I go on the liver. And wow. This is very nice. I'm, traveling inside of the body, going, on the kidney. I can see very well the form of the kidney, the volume. Oh my goodness, very nice.
And you can also zoom in using the joystick. Yes, you have to press, and while pressing, you have to. Yes, okay.
Very interactive. It's easy, very easy to use, I should say. And I can see very well if there are, some. So this comes from the CT scan, right?
Yes.
Okay. Oh, too much. I was, too much in. Now I needed to go back.
You can use the joystick to go back. You have to click, and while keep pressing the joystick, you have to go on the other. Yes, but just moving the joystick.
Okay.
Not the controller, just the joystick. So you have to press and move your finger down. Press and move your finger down while pressing the joystick. No, the joystick. You have to press the joystick, and then moving the finger down while pressing the joystick. Okay.
Okay. Oh, okay. It's going back now.
Yes. In the meanwhile, we have two devices. So, if you want.
Somebody else wants, to come with me inside of this exciting travel inside of the body. It's unbelievable. I am in now. I cannot go back.
You have to press. Yes, I can help you. You have to press and go and move your finger down. While keep pressing, move the finger down. On the other side. Yes. Now click again. Yes.
So for the resident, this will be very nice and exciting. You should trust me. Very nice. New technology to understand better the anatomy of the kidney and to decide what is, the right kidney that will go for renal biopsy. So we are, doing something new. I was starting doing renal biopsy a long time ago, 1987. And, technology now is improving. And now we can know very well what kind of kidney we have if we CT scan, our kidney. Okay, thank you very much. If there is somebody else that wants to come and to try, please do it.
Can I say just one last thing, if it's possible? Because that's just the start of our work. We are working to implement similar solution with augmented reality, and we are working to create immersive simulation, for example, for renal biopsy. It's on our timeline, and we hope to enjoy you this solution soon. Thank you again.
Thank you very much.
Well, congratulations for this team, Mauricio. It's really fantastic. In fact, this is the future. I would like, also in the same line as you, highlight that probably the 3D printing, the 3D design of all we are working in clinical practice is the future. In fact, we work in the same way. We work also trying to understand that there is a huge gap between the learning and the assistance. Cover this with or related with 3D. As we have to work in all the knowledge of anatomy, invasive procedures, and so on, and in the world of vascular access, for this reason, we do exactly the same. But we try to adapt this to the use of our hands, to introduce the ultrasound needling cannulation in the jugular vein, in the vascular access, or in the kidney biopsy, and trying to translate this to use of our hands, and even to use the ultrasound, and after introducing ultrasound, introduce the needle. And this is key point. That we do is to take of the body, as Mauricio says, all that we need, all the vascular access, all the jugular and earth carotids, all related with the kidneys, and we customize that we want for teaching. That means that we can put kyst and we take out kyst, put a transplant node, modify the evolution, the movement of the veins or the arteries. And after do this, we translate this to different concepts. In fact, that we do is all 3D dimensional work, we adapt it and we introduce in virtual reality and also in these synthetic models. You will see later as we put the arteries, the veins, the stenosis like in a human being, but just in synthetic models of virtual reality. And this allows us to make a sorry, the ultrasound night-guided calibration. In fact, you will see later on the same position of the vessels that you have in a patient. Place it inside here in order to check it with the ultrasound. Also, we can do the same with 3D printing and so on in order to make the endovascular procedures, stent placement and so on in all the branches, not line tubes just here, but really the morphology of the veins and so on in order to imitate the stenosis that we have in our patients. And the same for catheter placement. And this is very important because, as you know, the left catheters are difficult to place. And then we print all related with the left area and the right area, right area, in order that when we place a catheter, even tunnel catheters, we have to go through the left subclavian vein and so on. And after make the cannulation, the needle and so on, put the catheter. And this is important because when we go through virtual reality to all the complex path of the arteriovenous access, for instance, we can do the mapping of real arteries and veins, and we do the mapping with ultrasound, and we can check with ultrasound what happens in these vessels. And after we create AVF, and we check how to use the ultrasound in order to the best approach to the anastomosis or even the stenosis. And this can be used for everybody, have you seen, and mainly even all the specialties and the nurses. A key point is that if we introduce this not only face-to-face meetings with the synthetic simulators, but also with all related with this, you will see later on, because we are going to know the practicals with the practical area just now with the physical simulators, but after the lunch, I will show you some videos how we can put the glasses, we can take with our hands the models, make it bigger, make it smaller, easily give put the patient in position just to make the kidney biopsy, use ultrasound to check the kidney, and after this, introduce the needle on the kidney. Well, thanks. After this, just slides in order to understand how it works, I would like to show you with the help of the cameras how it works this in this kind of simulators. I would like to show you that. Yes.
Before we go on the practical part, there is a participant that has a question for Simone. How long does it take for the conversion from the scan to the 3D model? Do you need an expert intervention for the process, or can it be done by anyone who has a regular knowledge of technology? Please, Simone, can you answer in this way? We go on with the practical part with Professor Ibeas.
Yes, thank you for this question. The time needed, it varies from model to model, because there are some models very complex and some others not. So it's around 1.5 hours. It depends. And we are working to improve, to short this time with automatic algorithms. So actually, we need experts to complete this task. We are all we can do all this type of reconstructions. Me, Sebastiano, and all the other, all the team of PrintMed. But in the future, it will become automatic.
Oh, thank you very much, Simone. So you can understand that this is a new technology, is under patenting, patent is pending, but they, shared today with us, but technology is flying, I should say. So it's improving day by day. So, Professor Ibeas, let's go with the practical part. The residents, they want to put hands, they needed to move hands. So please, let's give to them a touch on what they will do to reduce risk management before going on real patient. So they can use the phantom, they can use the mannequin, to have, the first, step in the interventional nephrology.
Thank you, Tino. Well, the main idea of the hands-on training is that after acquire all the knowledge that in theoretical classes and so on, go to the area where we have to learn how to do the procedure. And this means to get the skills. For this, we have to know how to use the ultrasound first. And the ultrasound in the kidney, in the arm, in the jugular veins, everywhere, in the cava. Second, we have to know how to use not only ultrasound regarding the vessels or the structures, but also with a third object that is the needle. And it means that we have to be used to use the ultrasound with the non-dominant hand, because when we make exploration, we use the ultrasound with the dominant hand. But if we are going to do needling, we are going to change the ultrasound to the non-dominant hand, and after with the needle, puncture. For this, we have to train to this. If we train the patient, we can harm the patient. For this one, it's very important to use different kind of settings of any kind to train this. For reason, we can try to use this with phantoms, where we have introduced the different size of vessels of the veins, or different depths, or different diameters of the vessels. I will show you later, in order to train to search for the anatomy and even the needle. This is mainly for us, for the jugular vein and for nurses. After, if we in the arms introduce with this kind of technology, with 3D printing at the segmentation, this inside of the arm, we can, with the ultrasound, explore the arm in order to choose the best area to make the needling, or even to understand how it works, the approximation or the orientation, the profile, in order to understand the 3D anatomy. And this is crucial for the catheter placement. For catheter placement, it's completely different to put a catheter in the right side versus the left side. In the right side goes directly the tip of the guide wire to the atrium and after the inferior cava vein, but in the left side, the tortuosity of subclavian vein, we can have problems, and we have to be careful to learn to do it, mainly when we introduce the dilators and so on. Well, now we are going to go here with the simulators. And you can focus Well, here I would like to show you that you have different vessels with different diameters, different depth. The same in the veins in the human being. And this way is when you can train before to go to the other model to put the needle in. For instance, here you can check how the diameters of the vessel change. Or in this other one, that is thinner, goes more superficial. Let us go deeper. And here, you can see how progresses the needle towards the vessel. Okay? Then once you understand how it works, for instance, longitudinal and in plane, you can train to do it transversal, out of plane, and check how progresses the needle until the vessel. Or goes lateral, I move the vein, the needle, I introduce again, and I go directly to the vessel, as you can see here. Okay, once I train with different kinds of vessels, I can go to the arm for. Let's go now, for instance, to an arm, because with this kind of arms, we can use it for surgery or move it for veins and so on. Then, let's go to an AVF. And in the AVF, we can check here from the distal part You can see here the anastomosis. Here you can see the anastomosis, the vein in the artery, the radial artery below, the vein, and here you have the cephalic vein, how progressive, dilation. Here you have an stenosis. Let's go, the vein. After we're going to get the bifurcation, here we have below the arteries, bifurcation cephalic and basilic, the cephalic here with a stenosis, increase the diameter, and here we can see how joins something. This is a graft. We have introduced a graft. And let's go now to see the artery. You see below the artery, the radial artery. So we'll see how the radial artery joins to the ulnar artery, just here. And here we have the brachial artery. And here we have the brachial artery, just below the basilic vein. And here you can see how joins the graft to the brachial artery, and to the left the basilic vein, the brachial artery below, the graft how it joins, and this graph you will see how it joins here to the cephalic artery, the cephalic vein. In this way, we can understand, we can train to make the best approach to see how it works the ultrasound. For instance, if we go here, we just learn to make the approximation to put in plane, out of plane, and so on. And the main point is even for needling. Even in narrow areas, let's look for instance, a more difficult area column A. For instance, here we have a teeny vein. You can see the teeny vein, how can be cannulated easily, okay? So here we have the real anatomy. If we go to the neck, well, an important point that Nuria reminds me is that here you can be trained in order to use the different anatomy of when you work out of plane, or you work in plane, or you work in the vessels transversal and longitudinal. This is a fantastic way in order to be trained to use the progression of the needle, as you see here, out of plane, longitudinal, or transversal, okay? Fantastic. Then, if we go to the neck, I would like to highlight that in the neck, we have the arterial branches. That means the carotid, the external internal, and the external jugular vein, internal jugular vein. Here, we are in the right side. In the right side, we have the triangle delimited by the two parts of the sternocleidomastoideum and the clavicle. And here, we can find, for instance, here in the left side, you can see the external jugular vein that goes to internal jugular vein, and internal jugular vein that's there, the carotid artery just below. And this is important for the approximation with the ultrasound in order to understand that if I go with the needle without taking into account the artery, as you can see here, the vein, as has the artery below, can create a situation in that the needle goes through the two walls of the vein, can go through the artery. For this reason, if I change the orientation of the probe, I can see only the artery or only the vein in order to be cannulated with lower risk. This is for the left side, and in the left side we can see how it joins here the external jugular vein to internal jugular vein, and here we can check the best area to, like here, just close to the supraclavicular area in order to put the needle, as you see here, in the confluence, in order to put the guide wire, in order to make easier to put the catheter placement of tunnel catheters with a lower level of kinking. As I can customize the real anatomy, then I can introduce in these kinds of synthetic bodies the real patients, but customizing the position in the neck. For instance, if I want to do a difficult approach and I put the veins in a different place, then I'm going to find that these veins are more lateral. For instance, like here, I have in the middle, the internal jugular vein, the external jugular vein there, and the carotid area below. Here I can see how it joins the external jugular vein to internal jugular vein, and after goes just close to the supraclavicular area to the basilic vein. And here I have the artery just below. In this way, with the movement of the hand, I can check the best area to make the cannulation. As this is all real patients, I can discover more aneurysmatic area, more narrow areas in the vessel, stenosis, and so on. Then we have to make the needling, and directly using the Seldinger needle, then I can take profit for this. For instance, here I have the anatomy of all the vessels in the neck, in the right side, or in the left side. I can choose the best area to put the needle. For instance, here. And you have the same feeling like a human being, how enters the needle. And if I commit some mistake, that I'm going perhaps to some area that I have not clear, perhaps lateral to the vein, I can move the needle in order to damage the patient and go to a better part. Or for instance here, perhaps this is a better area, okay? This I can go here. I'm feeling how it works, okay? I enter here, okay? Or for instance, in the right side, just here, I'm going to choose here. I put the image in the middle, the needle in the middle. No? Perfect.
Now it's very close.
Perfect. Perfect. I'm in, okay? And then is when I can move the needle, take the plier. And if I have some problem, I will have the problem in synthetic model. I feel how it progresses. If I have some doubt, I can check how enter in the vessel, as you can see here, with ultrasound. I can do all the procedure there in the real sitting. I can introduce the dilator. And the more important point is that I can do this in the right or in the left side. And here is when I can teach to the residents that never forget to tie very well the guide wire, to introduce it, to take out, take care of the bleeding, change to the next one. Perfect. I'm going to go to take the more wider one, the bigger one. Then here I have to take care of the tip of the guide wire to introduce it. And I have the same feeling in this kind of synthetic models like in a patient. The patient is going to bleed, take care of the bleeding, take care of the tip of the guide wire. And after you can put the catheter. Never forget to put saline inside the catheter before. Take care of the lines, the arterial line closed, the vein line open. And here the more important point is take care of avoid to lose the control of the guide wire. And after, introduce it like area patient to the end, okay? Please, our radiology. Well, okay, then you can place it wherever you want, okay? And then the more important point is that finally you can do this with the tunneled procedure. Because finally, if this can be repeated several times, and the important point is that if I put a tunnel catheter...
You should also add that you can use different color of...
Exactly. Then the more important point is that this kind of patients have the external jugular vein, internal jugular vein, the different branches of arteries, then we have different trajectories for all this. And you can introduce in the radial, in all the arteries, the red color, as Loreto says, and the blue color for the veins, in order to know that you are inside, okay? And a key point is that it's easy to put a non-tunnel catheter, but tunnel catheter, we need a training for make the tunneling. And for this reason, with the tunneling, we should be used to use it and to teach the students. Perhaps the camera, perhaps better in this way. Well, then you have to see the students to make the tunneling. For instance, as we know that we have to put the tip of the catheter in the atrium, and the catheter should enter by the interjugular vein, we have to make the trajectory of the tunnel catheter, just for instance here. Then, if I give the shape that I want to the tunneler, then I can introduce this wherever you want, and progress inside the patient until, and with the same mistakes that I can have in a patient. Or after go to the progression, taking care of the subclavian vein until you reach here, and after the guide wire is here, you introduce the different dilators and so on, as you know. Then, and this allows you to use the different kinds of approaches with a tunnel catheter, the anterograde or even the retrograde. And this means using the other tunnelers. You know, this kind of catheters, once you have placed the catheter, then you have to use this kind of approaches in order to reach the catheter and after put it under the tunneler. And this is the same. You can introduce this, progressing, after it reaches this area, and after you move it, and so on. So, in summary, the main concept that the residents should know is that you have to acquire the basic skills in order to understand how it works, the ultrasound regarding the anatomy. Second, to learn how to use the ultrasound and the needling. Third, how to use the ultrasound and the needling in different anatomies, the arm or the neck. And third, once you have used some devices like the catheter, understand that this should work, and then go for the lessons to the patient, reminding that the tip of the catheter should be in the atrium, take care of the kicking of the catheter in the supraclavicular area, take care of the tunneling, and so on. And all of these different steps is better to do it in simulation models better than in a patient, okay? And the last aspect is surgery. The surgery is important, that once we have made the mapping and so on, and we're going to go to surgical procedures, is understand all the different steps in surgical procedures. That means from the skin to the different tissue that we have under the skin, like the muscle, the fascias, and so on. Well, this kind of models allows you to make any kind of surgery. As you can see here, the ideal situation is that with the synthetic tissues, be able to make the anastomosis, understand how to do it between the artery and the vein in the wrist, for instance, or in the elbow. Here you can see the bifurcation of the radial artery, the ulnar artery, the cephalic and basilic vein, and then when the interventional nephrologist or surgeon is explaining to the patient, to the trainee how to make the best approach to the patient, he will have to explain the different kind of anastomosis in the different branches of the artery and the veins, or even reconstructions in the Still syndrome, like the Rudy, the Pava, the Dral, the Drill, and so on. It's better to understand this in this kind of procedures. And even we can put the grafts, the anastomosis between the artery and the graft, the vein and the artery and the graft, the vein and the graft you can see here. Here we have the radial artery that I'm going to put my finger. This is the radial artery with the, yes. Here we have the radial artery. This is the anastomosis with a graft. The graft goes under the skin until connected to the basilic vein. Then, if I go through the ultrasound examination, I understand all the anatomy, and after I go to the surgical procedures, I will understand step by step all the different phases to the fistula creation. And this is crucial to feel it how it works. For this reason, when we go starting with all the different processes, if we take a scalpel, I have to feel for the first moment how I cut the skin. This cut was inaugurated by Dr. Gesualdo. And here I feel how, Marta, please, oh, what can you? Then here we can see how I cut the skin. I reach the muscle. Here we can see the fascia. And after we cut the fascia, we can discover the artery. Well, we can, as I told you before, we can see how discover the artery, the vein, the skin, the muscles, the fascia. And after I discover the artery, the radial artery, and the vein with the same feeling of the tissue. If I want to create an anastomosis, and I want to cut the artery and the vein, please, Marta, I want to help you. Perfect. I have the feeling that you have to maintain this here, this each way. Here I can see the other artery, the radial and the ulnar. Okay, and you can see the different branches. Let's see, Marta. Put the finger here. Perfect. Then I can choose the different anastomosis between the radial and the ulnar and the vein. And if I cut the vein, or I cut the artery, coge tú este. Perfect. Then I make this. I can make the incisions to make the cuts. Okay. I can cut the vein, or for instance here, I can cut the artery with the same feeling of an artery, okay? And even you can check the quality of the scalpel, because this is the scalpel of the catheters. And here you can see how the vein, the artery opens. You can see the hole, the anastomosis, the diameter of the anastomosis, in order to take care that shouldn't have more than 4 or 5 millimeters and so on. If you want to introduce here the needle in order to make the switches. Then you can fantastic. You hear the two arteries, the vein. Okay, fantastic. It's here.
Maybe we can try to turn a little bit this way. Okay.
Well, perfect. Then I'm going to take. Loreto, I need help.
You need help?
Yes, then take here. Perfect. In others, I take the stitch. And here you can see how I can introduce the needle and with the same fragility that the artery with the stitch. One here, another in the top here. Too big. I move it, and then with the same feelings. And if I move too much the needle, I can break the artery or I can break the vein. Okay, then with the different stages, I can go from the skin to the subcutaneous tissue, to the artery, to the vein, make any kind of anastomosis in all the area, and understand in a realistic way all the different procedures I can make with the creation of ABF. So, in conclusion, the point is that knowing how it works, the real anatomy, with the real anatomy, try to understand that I cannot customize the anatomy depending on what I want to teach to the patient, to the trainee regarding the patient. I can introduce it in virtual reality, as I will show you later on. And as I will try to put it in different models, this allow us to be very practical. Well, I would like to introduce you to Nuria Monil. Nuria Monil is the biomedical engineer of our team who develops all the clinician we have in our mind in order to put this here, and this really probably is the future. How do you see this, Nuria?
Well, I see the potential that this has, as Dr. Rivas was saying, is that you can customize the settings that you want to train in. So even though it's not to practice on particular interventions, you can get really complex cases that probably are not seen as often as regular ones, and that therefore people are not as used to training. And so there's a lot of potential in there. And the combination of the virtual reality simulators that we will show later as a previous step to understand the disposition of all the anatomical components and prior to using the simulators optimizes the process of learning even more before going to the patient.
And this is crucial because as we work with vascular surgeons, interventional radiologists, and nurses, we chose from the more easy cases to the more difficult cases. And then in this way, we can train to the residents of first grade, to the more advanced residents, or even the surgeon, interventional radiologists in very difficult cases. Because even we can customize the difficult cases to more difficult cases, or even to the solution that we can get it, using the knowledge of the biomedical engineers. Well, that's all. If you want, we can finish here, Marta, and then we go to the next stages and we show the virtual reality afterwards, okay? Any questions?
If anybody then wants to touch or try, now we are going to lunch, but we can find a few minutes to touch.
So let's see if there are questions from the floor and from, the online side. So I would like, that the participants, since there are also some residents that are connected, I would like to share with you, the feeling. So what is your feeling? Do you like this kind of approach? Can you write down, in the chat if there are suggestions and if you think that this should be the way out to train, resident and to reduce risk management. Professor Ibeas showed to you that we have phantom that can be customized, and so I can, you can trust me, you have the feeling that you are on a human arm, that and you are, working on a jugular, and you have the feeling when, you use the needle that you are going, in the same way that you do in a human being. So please try to write down in your chat what do you expect from us? Is what you were looking for, or you were thinking that in a different, educational model. Do you like this kind of approach? So we will do for all of, the 4 curricula, for the VAS, for the reuse, for the REVAS, for the REVAC, for the remap, for REPAD, we will use, the same approach. So all, the curricula will have in this practical part. So do you like it? What is your feeling? There are some answer or not yet. So we needed to boost them. Maybe they don't have, they don't know how to tip on the dashboard. And well, let's give, some, few minutes because they are thinking what to answer. So, Jose, you have other, other comments? What has been, in your experience, since you are organizing so many courses? So the participants have appreciated they are doing.
Yes, I think that this is an important point, Loreto, because sometimes when you are trainees, the trainees, they think that they know the main aspect, but sometimes they don't know really, neither the basics. And this is crucial. And sometimes it's a pity that the trainee be trained with the patient. For this reason, the 2 points to highlight are one, for the residents, they have go to the whole checklist of these procedures, and this is very important, and don't forget anything. I feel the same feeling that in the patients with anatomy. And the other point is even for the teachers, for the trainers, understand that anything that you have in your structure for teaching, you can do it in these kind of models. Because sometimes it's difficult to explain that the left side is more difficult. But it's more difficult. But if you train in some models that are not realistic, then you realize that it's difficult in the patient. For the reason should be the more difficult approaches, not only the singles, be used in the virtual reality simulators or in these ones. And the virtual reality simulators, the more important point is that the different kind of approaches you are going to do and you want to understand are the first stage, and this is the second one. Are 3 stages. Theoretical concepts, the virtual reality in order to understand all in 3D, and the best approach after, use your hands in order to do this, but with ultrasound and how to manage this. And third one, introduce the needling, the more important concept. So if you do the needling in 3D, you are going to understand this, and you're going to be easier to do it in these kind of models, in the phantoms and so on. So this is the rule.
But what do you think? What will be, the time for training? So how many days you think? So you said the first step is the anatomical part. So you needed to know very well the body. You needed to know very well what are, the contact between the parts. So the second one will be immersive reality that will, better let understand how, how our body is done. And the third one, you try with the needle in a phantom that is very close to the human body. So these are, the 3 steps. And after you go on the real life, and do you think that this kind of approach will reduce risk management in our resident?
The risk, you say, Loreto?
Yeah, risk management.
Yeah, the risk is be completely different. In fact, we realize in our courses that the residents fails always in the same points. Take care of the guide wire, the angle of the needle, the hands in the guide wire, not in the breast of the patient, and all this, if you train all these bottlenecks in the risk procedures to do it in these kind of simulations, then if you became your behavior automatic, this automatism you try to the patient. But if you get the automatism because you have risk procedures in the patient, then you are going to be afraid in the next patient. But if you train and you make that disappear the risk with the training in simulation models, you will have a more higher level of confidence when you go to the patient.
Okay, very, very well. Thank you so much. It's, time to break. If there are not questions, there are one question. So let's go to C. No?
Questions, but they, especially the fellows, sorry, no questions up to now, but the fellows really appreciate this approach. Obviously reducing the risk for the patients, but at the same time learning, so to give the best possible care, which is fantastic. So very positive feedback. It seems that everything was clear. Let me see, there's just one. I see awesome approach to learn and reduce the risk of our patients. Wow. So that's very nice. I think this is really innovative way to learn, excited to be part of it. So we're very happy about this. Thank you. Let's say, wow. So everybody is starting now. So somebody started first. Useful to practice, to reduce the risk. We already said this. Very exciting, new techniques. And they're all very stimulated to start. So I think this is fantastic. Oh, maybe they want to start a WhatsApp group. So
This is a very good idea. So maybe we can make, with the 40, students, we can make a WhatsApp, chat. Why not? In this way, there will be, the professor, the teacher, the mentors, and the resident. So Antonio, I think that we should proceed. Let's get, all the phone numbers, and we will have, fun together. Also because we will, get also, Monica, you will be inside with us if you like it. I don't know how much you will be busy, but that's good. So I saw that, they are reacting now. So we are going on the right track. So this is the right track. But now we are all hypoglycemic. So we will break, for lunch, and we will come back at 2:30 p.m. And because we have movies for you, we have some clips that Professor Ibeas have realized for you. And we will, close down once again with question and answer. So be prepared. Try to have lunch. In this way, your glycemic level will stay, on the right levels. And so have good lunch. The screen because there are some questions for Professor Ibeas. Well, first, all the residents are writing that they like it, this way to do education and to be trained. They are, looking forward to use the simulator. And there have been very compliment for your demonstration, practical demonstration, your talk. But there is one question for you that is asking, the simulator are very cool, thank you. How often do you need to replace the vessel on the dummies?
The vessels to be replaced, this is only in the surgical device, because the other ones is all the block. In fact, all the related with the ultrasound examination of the arm or the neck is a block with a lot of vessels where you make cannulation. So there are two concepts. One, the surgical. The surgical have place to make 3 surgeries in the radial artery with the cephalic vein, 3 surgeries in the ulnar artery with the basilic vein in the arm. This means 3. Luego other anastomosis in the basilic, other anastomosis basilic or cephalic, even 2 more, 2 more up, and 2 or 3 grafts. So you can do 3, 6, 8, more or less 8, 10 surgeries and a couple of grafts probably. Depending. This is in a regular situation with a first knee. If you are more accurate, perhaps you have more space. And then you change and put another block. In fact, in these simulators, you can use this kind of model, or sometimes you change the vein and you buy the veins. And this way, but if you buy the veins, you have only the vein. You have not the anatomy. The secret of this is that you have the anatomy, all the different layers, and all the structure that represents an arm as much as possible. And the other are the blocks of the neck or the arm. Then in the neck, if you use to, or the phantoms, as you have 4 or 5 veins, and if you want to cannulate, if you use a thin needle, you can use a lot of times, I don't know really, but a lot of them are relatively cheap. And the neck, if you use for cannulation a lot of times, but if you introduce catheters, depending on the catheters and the damage you do, perhaps you can damage it earlier or not. For instance, I would like to show you that this kind of tissue, for instance, you see, as you can see here, recovers the shape. Or, for instance, yes, these ones. This has the hole of the catheter, but even using the hole of the catheter, you can put more times the tunnel catheter. If you only use the needle, a lot of times. If you use for non-tunnel catheters the guide wire and dilators, more times. This is you have the internal jugular vein, the external jugular vein, and even if you want to calculate the carotid, you have more opportunities. Okay.
So, how many times do you need it to change? Let's say, how many procedure a min of procedure?
If the exact answer is difficult to say because depends of the quality of the management. As we assume the trainee perhaps damaged it, perhaps if you made it in the right side 1, 2, 3, 4, 5, 10, perhaps 10, 15, 20 in both sides with the all placement of the non-tunnel catheter. And the tunnel catheter, perhaps 4, 5, 6.
That is not too bad. 4
Yeah.
or 5 with the if you use the
With the tunnel, because you can make a couple of here, and depending on the damage, perhaps you can lose water. No? And if you use only for training for the approach of the needling, if you use a cell needle, perhaps over time, and if you use a fine needle,
up to 10, 15.
yes, or perhaps more. In fact, the classical models, other kind of models that are very hard, and these models are fantastic too, are more practical, but you cannot cannulate. Or perhaps if you use bigger needles, they are going to damage earlier. No?
That's right. Okay. Very good. Thank you very much. We have answered, but it's still your turn. You go with your clip, I think. So we have a clip from Professor Ibeas. Before, we will, and after we will try to close down, the meeting. So we go, do you want to present or we go straight with the clip? We go straight with the clip. Enjoy the clip.
I would like to welcome you to a new world, the virtual reality world. We are going to work with the kidney biopsy model. For this, we need our colleague, our simulation model. We have the advantage that we can become this model transparent. As you can see here, we can see all the abdominal cavity organs, the liver, kidney, the splenic area, the aorta and its branches, and we can use our tools. See my hands. Here I have now the ultrasound. And with the ultrasound, we have the advantage that we can use it in order to check all that we have, as you can see here, in our abdominal cavity. As you can see here, we are checking our kidney. Okay. Now we are going to use our second tool, the kidney biopsy. Then ultrasound has changed to my left hand, to my non-dominant hand. In this way, I'm going to be able to check where is the needle, transversal, or even longitudinal, as you can see here. In this way, if I can locate with the ultrasound the abdominal organs, for instance the kidney, and I can check the position of the needle in relation to the organ, I can use this as a fantastic model for a kidney biopsy model for training. Thank you very much indeed. Let's go to the next step. Let's go to the next step. We're going to go from augmented reality, like now, to the virtual reality. Here we have our model. We are going to become the screen transparent, and we are going to start working with our kidney biopsy model. We are going to take our model. We are going to put it in front of us in order to explore all the organs. Here we have the abdominal cavity with the different organs, the liver, kidneys, the aorta and its branches, iliac arteries, femoral, and so on. And we are going to explore the location of the kidneys. The kidneys are located among the posterior wall, where are the bones and the posterior muscular wall, and surrounded by the liver and the splenic area. We're going to put the patient in the position of the kidney biopsy. We're going to move it. The patient is decúbito prono, and now we are going to use our ultrasound. I have the ultrasound, and I'm going to insonate the kidney. I can see transversal or longitudinal. In this way, we can locate the best area to put the needle. I'm going to change the probe of hand. I'm going to take the needle, and in this way, I'm going to locate the kidney in order to use the needle in the area that I can choose. Here you can see an arm. This is the object where we are going to work. And this is fantastic because this kind of models allows us to see in a fantastic way how it works. A normal arm previous to the surgery, we can make here the ultrasound examination, the physical examination, any kind of procedure, and with an ABF. The same with the physical examination, ultrasound examination, and so on. This is the augmented reality. This kind of models allows us a fantastic training methodology. Let's go to the next step. We are going to go from the augmented reality that you see here to the virtual reality. This is virtual reality. Here we can see the arm. We are going to go to the two main issues of this workshop. First, the mapping, and second, the examination, the ultrasound examination of an ABF. Okay, for the mapping, I'm going to help you using the possibility of turn the skin transparent. In this way, we can see all the branches that we have to recognize with ultrasound. Here we have in red the arteries. This is the brachial artery, where here divides into branches. The radial artery, just until the wrist, and the ulnar artery. And regarding the venous system, we can recognize the cephalic vein, the basilic vein in the forearm, and here the cephalic vein becomes in the medial vein with the communicant cephalic, the communicant basilic, and here we have the cephalic that goes until the cephalic arc, and here we have the basilic vein, deeper, that goes from onto the axillary vein. When I use the ultrasound, then the main issues to take into account is that I have to recognize the minimum criteria in the arteries and the veins to have the best ABF. And this should be in the radial artery, as you can see here, a minimum diameter of a couple of millimeters. The same in the venous, and as you can see here, you can see the cephalic vein, and you can measure the diameter in the radial artery, in the cephalic vein. Then I have to check the hemodynamics. And this means recognize the artery in order to put the Doppler ultrasounds and study the peak systolic velocity in the radial artery. In the mapping, these kind of methods are very useful to understand not only the best approaches to the surgical approach in different areas like in the wrist or the cubital fossa and so on, but also if I use the endovascular approach to create an ABF. As you can see here, the two branches, the radial and ulnar, that came from the brachial artery, and here the perforating vein. Here you can see the approach that you can make using the two different approaches to create an ABF. or using the guide wire inside the radial artery and the vein. And here you can see how should be the approach between both the radial or ulnar artery and the radial or ulnar veins, in order to understand if I introduce the two guide wires, how to be placed, or the other approach using the ultrasound approach by the perforating vein through the wall of the vein until the artery. So these fantastic models are very useful not only for the surgical approach but also for the vascular approach. Okay, let's go now to the ultrasound examination of the AVF. For this, we are going to build now an AVF. Imagine that we are going to create an AVF between the cephalic vein and the radial artery, like here. Okay. Then here we have created an anastomosis. This anastomosis goes by the forearm until the antecubital fossa, and with the drainage by the cephalic and the basilic. And here we can see one stenosis, here another moderate stenosis, here we can see another stenosis in the cephalic vein, here you can see the drainage by the basilic vein, and these fantastic models give the possibility to understand better how it works the ultrasound. That is the main aim of this workshop. Well, if I check with ultrasound the anastomosis, then I'm going to be able, in transversal way, the diameter of the anastomosis, and also in longitudinal way, the diameter of the anastomosis, and check the stenosis. Another important characteristic, finally, of the ultrasound is that I can measure the distance, the veins, to the skin. And this is very important because here you can see the distance of the skin to the vein, and this is very important because can be measured with ultrasound in order to measure the possibility of the needling in different areas. We are going to work now in the muscular simulation model of the catheter placement. For this, we need a simulation model. This kind of virtual simulation models have the advantage that we can turn the skin transparent. In this way, we can check all the structures in the anatomy of the neck and even the breast, from the carotid, jugular vein, the central trunk, until the heart. Once we have our simulation model, we need our tools. The first tool is the ultrasound. With ultrasound, we can check how it works the location of all the vessels inside the body. And the other tool is the needle. With the needle, we can use the ultrasound in order not only to check how are placed the muscular structures, but also how can I access to these structures. Let's go to the next stage. We are now in augmented reality, and we are going to go to virtual reality in order to be able to handle the different tools that we are going to use to the catheter placement. Well, we are now in the virtual reality. Here we have our model. We are going to take it, and as I showed you before, we can become the screen transparent. Here we can see all the structures that we have in the thorax. The heart, the aortic branches, the superior cava vein, the intermediate trunks, the internal jugular vein, the right, internal jugular vein in the left, the external jugular veins, the carotids, the bifurcations, internal and external, and the subclavian arteries. In this way, we can check where is the area where we are going to work. We are going to place now the patient in the position where we are going to work. Okay? Then we have to be aware that if we use the anatomical reference in order to place the catheter, we have to recognize the triangle that is formed by the two branches of the sternocleidomastoideum muscle, the clavicle, and just in the middle, we are going to find the carotid and the jugular vein. If we use the anatomic reference without the use of ultrasound, we can make the needle just here in the direction of caudal area, little lateral, with the risk, as you know very well, of a close to 10% of complications related with the misplacement of the jugular vein in relation to the carotid. For this reason, it's crucial to use ultrasound. Now, we are going to use ultrasound, and in this way, we are going to check how it works. If I place the ultrasound in the neck, you are going to see how I check the position of the jugular vein in relation to the carotid artery. Well, we're going to go just now to the next step, that is the use of the needle. Then, when I use ultrasound, usually I use it with I should use it with my dominant hand. But when I have to use the needle, as the needle has higher risk, I have to change the ultrasound to my left hand and use the needle with my right hand. Then in this context, we are going to understand now, in this third step, how it works, the placement of the needle in relation to the probe. Well, the first consideration should be that the orientation of the probe in relation to the vessels should be named transversal or longitudinal. This is longitudinal and this is transversal. But the location of the needle in relation to the probe is in plane when it's in the same plane, and here you can see the needle, or out of plane. And this is very important because when I go out of plane, I don't going to see the tip of the needle until the tip of the needle is in the sonation beam. I place the ultrasound beam. I can use the transversal approach of the beam in relation to the jugular vein and the out of plane location of the needle. One. Second, longitudinal and in plane. And here you can see how it progresses and enters in the vein. If you go through the two walls, you have no risk of needle the carotid, but if you don't have the control the carotid, you can needle it. Okay? But here, for this reason, it's very important to use ultrasound in order to check where are the needle, where is the needle, and where are the vessels. So, longitudinal, the vein. And the third one is when I use transversal and in plane the needle. In this way I have under control the carotid artery. If I go through the vessels, I don't want to harm the carotid artery. Like this. This could be very dangerous, as you can see here now. The last step should be the placement of the tip of the catheter in the atrium. This is very important because once we have placed the guide wire in the jugular vein until the atrium and after the pericardial vein to be saved, we have to put the tip of the catheter in the atrium, just here, in the middle of the atrium. And this is very important to understand in order to avoid the dysfunction of the catheter. Well, this should be the trajectory of the catheter, the jugular cava vein, until the middle of the atrium. And the middle of the atrium is where it should be placed. If we check it with the ultrasound, we are going to see where is the atrium. And just here in the middle of the atrium is where it should be placed. That's all, dear colleagues. Thank you very much for your kind collaboration, dear colleague. This kind of model really realistic advances in real anatomy are very easy to understand. It's a huge help for training, mainly because we can understand better the location of the anatomy, we can use the ultrasound, we can use the needle ultrasound, and we can understand how it works, the anatomy, in all these contexts. Well, thank you very much. That's all.
Thank you very much. Nice clip. Professor Ibeas, do you want to comment? Should be this the right way, to start simulation with immersive reality or augmented reality, or you think that will be much better going on the Phantom? How do you combine the two technology?
Probably the first, as all in all disciplines and mainly in medicine, first you have to learn, after to understand, and after to practice. Then, after learning after all the theoretical classes, the virtual reality probably should be the next step, because the virtual reality allows you to make the immersion in 3D, all different concepts. We should remind that in nephrologists, we are not surgeons nor radiologists, and it's more difficult for the main part of the nephrologists to think in 3D. We are not used to that. And the immersion of virtual reality allows us to understand very quickly all this. And after you go to the synthetic models, it's going to be easier to understand with ultrasound that you have seen in 3D. And mainly because the 3D models allow you to use the ultrasound while you see all the structure. Because when you want to do these models, you're only going to see the vessels with ultrasound. But with the virtual reality, you see all the vessels and you understand how the ultrasound moves in the space.
So first step, simulation with the virtual reality, and the second step will be, using the Phantom, because you were showing to us that you were, let's say, you were traveling inside of the vessel. So you were counting the vessel, you were followed the vessels. So it was very easy to understand what will be the right vessel that will get the needle. So this will be. So there are questions from the participants. Can we see? Dr. Fontana, nothing. Are they now coming back? Let's see if there is somebody that wants, to ask specific question for Professor Ibeas. There are questions from the floor here? No? Well, I think that with this clip, we can go, we can proceed to the last, presentation, few slides, to sum up what will be, no, is not this one, is the next one. You have another one, my third presentation, and we are going, to the conclusion, and after, the multiply event, we will start with the first curriculum that should be the remap, and we will meet each other in presence because we will have the real hands-on training. So they are waiting for it. So they are, pushing for it. They are saying, we would like to come and try with our hands because, too many words, but what they like it is to try because they care regarding the patient, because they want, there was, somebody on the chat that was reporting that this is the right way to reduce the risk management. So is for the patient, before they go first on the patient, they want at least to handle what is, and they want to feel, because it's not easy to start. Well, actually, Gallieni was reporting his first experience, he was missing the vessel in his first. So maybe this will help a lot. So we think that N-PATH course will become in the next future the standard for training. Well, this is the right, I think, we think, the right knowledge triangle, a new path for interventional nephrology, because research, education, and innovation is embedded in the same program and will contribute to respond to the challenges such as the globalization and the technological development, which are radically changing the landscape of higher education of the future. I think that what we are building together, Jose, I don't know if you have my same feeling, is something that for sure will let the resident become more comfortable going to the theater when they will do the first surgery on patient, because it's not easy. I remember my first renal biopsy, I was scared and I didn't know what to do. I was, caring for the patient, because always there is something, this feeling that let you don't stay very well. So coming back on the slides, thank you. Let's say that N-PATH will close the gap because fits its approach to reinforce European policy aspect in the educational landscape, because first there is this very strong cooperation between universities and small and medium enterprises. We saw this morning, Simone was showing us a patent pending for a new method to do immersion reality. We will be able, to use new digital technology, and as you know, Jose was showing to us innovative methods and tools for training. They are very updated. We are using, the state-of-the-art technology right now. I don't think that, Jose, in the world there are, better phantom dummies than what you were showing to us. And actually, thanks to the e-learning platform, there will be also the possibility to review the clip, because we will load inside of the e-learning platform, right, Valentina? We will be able to load all the clip that we will do together, we will realize together in the next two years. So I think that in the next 2 years, we will have a lot of educational materials, to do better our educational program. Moreover, well, actually, what we would like to do is to create what is, the approach that is being called flipped learning approach, that are, the blended approach. When you put together the practical part to an e-learning part. And for this reason, we will be also in touch with the participant using also social media and the e-learning platform for distance education. But what is more, I think, is exciting the participant is the practical hands-on training. So the interventional nephrology, doing, renal biopsy, vascular access, peritoneal catheter placement will be supported by innovative technology. And I saw today, realizing a WhatsApp chat, it's already making networking. So now they are already asking, let's stay together, let's follow better, the N-PATH course. So we will try with Antonio to create this WhatsApp networking among mentors and students. This, is I think the right way in that, the mentor should follow, because students or residents, they are asking for. And so since we are in the academic, we should do it. And you see what is happening in the world. There are, many papers coming out. And actually, what Professor Gallieni was suggesting to me, send me a WhatsApp, since, WhatsApp now is the best way, to communicate, saying, it's time, Tino, that we write together with all the tutors and the mentors, the first paper on N-PATH, describing what we are, trying to realize. That is also what is asking, the European community. So I will try, to draft in the next, weeks, couple months, the first draft of our paper, to introduce this new kind of educational path, to the nephrological world. What do you think, Dr. Fontana? I think that we should do it. And maybe we can, send for publication in one of the NDT journal. And maybe we can do the same for VAS, back to back. Maybe, you can help me with VAS and we go on the other side on for the nephrology. So I think that it's time to move on. So the academics should realize that, the educational program are changing, that our residents are asking more, and they needed to do practical part. So we need what we call cross-fertilization, because the cross-fertilization create, cluster, promoting exchange of good practices and mutual learning. And networking, the meaning of networking is good practices and mutual learning. So I am learning a lot because actually I'm trying, to visit all the partners, and every time that I travel and I visit, I learn. And for this reason, I thank already Professor Ibeas that, we spent a day together, and that was very useful for all of us. And we should also remember that N-PATH is devoted to strategic exploitation of the results that we will achieve together, and methodology tested during the project implementation, with the ultimate aim of ensuring the valorization and transferability of best practices beyond the project time span. And this will enable us also to build up new projects, because the technology is going crazy. I remember, if you think regarding the phone, when we started to use it, they were big phone, and very heavy phone. And now every year we have new technology. G5 connection is arriving very soon. So also for, educational program, we needed, to stay updated. And with this, I would like to close down our Multiplied event, thanking again all of you and Mrs. Fontana and his team. The ERA is not anymore EDTA, the European Renal Association, that organized this meeting in Parma. Thank you very much also for the good dinner that we had last night. And I would like also to thank all the participants. And before I close, I would like to know if there are some questions and answer before we go home. There are not questions. So we are looking forward to meet the class. Now it's time to start the educational track and have fun. And I'm looking forward to meeting you in presence. And for sure will be a good journey together. And thanks again for being with us today for all these hours. Thank you very much, and ciao. Good work. Oh, we have a question. Yes. Please, Martin. Just a second.
Are you planning to open a call for a new course and a new class in next year, or somewhere after that, or is this going to be a single event?
Well, actually, the class have been already constituted, and the class will start the program the October 1st. And they will last for 2 years. Right now, what we are doing on the basis of the first experience, building up a new project that we hope that we will send out in February 2022. In the meantime, there will be other multiplier event the next one will be organized by the Vascular Access Society, right? In Barcelona or in Israel, I don't know, they didn't decide it yet. So because there will be some multiplier event for all, you know, of you, like, you know, you were invited to this multiplier, because this is an educational program, so only, you know, resident can get inside of the program. And when we will finish in 2 years, the platform will be free, because the European community is telling us they should be free. So everybody will be able for 2 years, and for other 2 years. And for this reason, everybody will have, you know, the possibility to get in. So these are, you know, the rules from European community. Of course, we will try, you know, to realize networking. Our, you know, vision and our mission is to create networking. I am sure that the European Renal Association, as well as the Vascular Access Society, after, you know, this experience, you know, we'll see what they will decide. But I think that we needed to create a community based on new model of education. And I think that the society, the European society, will stay, you know, together with us, because we needed to create a community. So this is in the next future. I don't know if Jose or Monica wants, you know, to add something else. I don't know if this was the question for me. I know that now, you know, will explode. Everybody would like, you know, to do the N-PATH course, because there will be other residents that will ask for it. But we will see. Maybe we will organize other parallel courses in, say, yes, Mrs. Fontana.
Actually, I have nothing to add to what you have already described very well. But there is a question, so I will read it. Are you thinking of adding an evidence-based nephrology module with the aim to teach searching for evidence, critical appraisal evidence, and understanding the impact of limitations of evidence? So you have opened a can of worms, if I might say.
That's right. Well, actually, I was telling to Alberto Mandoli that just, you know, 3 days ago, the guidelines for GN were published, for example, and inside of our module of REMAP, we will have the guideline, the new guideline that just came out. So we will review together with the residents these guidelines. Of course, the state of the art will go also with the evidence. I am sure that in all the modules regarding, you know, the theoretical part, you know, we will cover what is, you know, pros and what is cons, because there are pros and cons as always. And we needed also, you know, to update our modules, our curricula with the guidelines and with the evidence base regarding, also because we are talking regarding interventional nephrology. And you want to add something, Jose, right? Please.
No, finish.
Well, I'm done actually, saying that we needed, you know, to go in this direction, because you know, if you think regarding risk management, sometimes the patient, you know, there is the malpractice. So we needed, you know, to teach what is the best for the best patient at the right time. So it's not an easy task. And what do you think?
I totally agree with you, Tino, because really our secret should be with you, the residents, go beyond the evidence. Because it's very easy to consult the guidelines. Sure, all the teachers of this program are going to put first the guidelines on the table, and after review papers and so on. But you will realize, for instance, in vascular access, that we have new guidelines from the United States, from the European Society of Vascular Surgery, from the Spanish Society of Vascular Access, the EMAF, or the NDT, the European Society of Nephrology, the ERA. And you will realize that the guidelines, with the same reviewers, with the same patient, the same literature, give different advices. What happens? So our secret is going to be not only give you the evidence, but how to interpret the evidence and going beyond the evidence. For this, you need enough training in order to understand how it works to manage all this knowledge to keep you alone in future and be able to take your own decisions.
Well, I think that this question was very good, Monica, because we have a different setup in different countries in Europe, I should say. For example, in Sweden, I know that the nephrologist doesn't do renal biopsy, but is the radiologist. The most of the time is the radiologist. For example, the vascular access in some country is the vascular surgeon, is not the nephrologist. So there can be some problems because there is not the same approach in all of Europe. For this, I think that the society should help in this. We needed to homogenize. We needed to have a core curriculum that should be, the same for everybody. And I think that the European society should work with the national society, trying to homogenize the track. Because if we were talking last night, when we were having dinner, that I think that we needed to have the right core curriculum for our specialty. Also to know what we can do and what we cannot do, and in which way we should do it. This is, I think, was the question that was coming from the participants. I don't know if there are other questions coming out, but I think that this is very important to discuss together. And for this reason, I think that we needed, to have on board the European societies, because it's, the right place where to solve the problem. So it's the only way that we can do it. I don't know if Jose, the other one, agree with me.
No, nothing to add, Tino. Really, the future of our specialty depends mainly of the agreement of all the societies in doing the same for the patients, because the confusion for the residents finally is traduced in worse control for the patients. So the secret of this is be aware that all societies should work together for the same aim and avoid to look for borders that doesn't exist.
Very good. Thank you. Thank you for this comment. So there are no other question from the virtual platform. From the floor, there are not other questions. So it's time to say goodbye to everybody, and we'll see each other in presence. Ciao.